jobs was actually a volunteer position that I did outside of a 40-hour clinical position that I had that was paid. And through the volunteer position, I really started to learn a lot about poverty and food insecurity and how that influences health behaviors, because I was volunteering as a dietitian in a food pantry among people with compromised immune systems who had also a lot of other medically complex conditions. And I eventually ended up working in that space full time for about 10 years, doing not only program development, we transformed our food pantry to a food as medicine model food pantry, and also had a lot of other social service wraparound programs there. But there was one instance of a patient that I want to share with you that really made me commit full time to wanting to address food insecurity as a social determinant of health. I was counseling this young man who was about 21, 22, and he came to me because he had lost a lot of weight. I did my nutrition focused physical exam and found that he was in the severe category of malnutrition. He had noticeable loss of muscle mass. And actually, if you had put the level of his muscle mass on a chart, you would have seen that he was in really the highest risk category for not only hospitalization, but if he were hospitalized, chances were he would not be leaving the hospital alive. His muscle was that depleted, and his immune markers were also in the tank. So he met with me for an hour, we talked, I gave him a lot of education about calories and protein and how much he was going to need to have to be able to gain that weight back. And I asked him to keep a food log for me and to come back in 2 weeks and we would sit down and explore that food log together. And he came back to his appointment, which, as we know, in working, with vulnerable populations, sometimes they don't even come back for their second appointment, right? So I was pleasantly surprised to see that he had come back, and not only had he come back, but he had filled out every single page of his food log. And on every single page of his food log for breakfast, lunch, and dinner was ramen noodles. That was all for an entire week. And sometimes I cry a little bit whenever I think about this story, because it reminds me of how much people really do want health, how motivated they really can be to change. And oftentimes the barrier to change is really, they don't have the resources to change, even though they may have the knowledge and the want. So I have really tried to bring that philosophy into my teaching and into my projects, so that more patients like him can really meet a responsive healthcare system that can not only provide the education, but provide the needed support that's necessary. So that's the orientation I bring to things, is a little bit of that lived experience. So we do have some session objectives for today that are defined here. I realize there's such a variety of people on our call today that some of this might just be total repeat information. For others, this may be kind of some of these areas might be a little new, or maybe you just need an update on where we are on the science. So hopefully there'll be a little bit of something for everyone, but would like to make sure that you all have a good, solid working definition of what food security is, and then also in contrast, what's the definition of food insecurity. I'd like for you to be able to also describe how food insecurity can affect dietary intake as well as eating behaviors, in addition to other lifestyle behaviors that we don't really think about have anything to do with nutrition, but in fact do. I'd like for you to think a little bit about how food insecurity might be affecting healthcare costs in your state, and also contributing to poor health outcomes. And I'll have a couple of examples for obesity, depression, diabetes, and hypertension. I'm going to present some rationale as to why food security is first a necessary foundation for health behavior change in your patients. And then we'll introduce some clinical response models for food insecurity, and then we'll expand more on what those models actually can look like in some of the remaining presentations for today. And so I've divided our talk up into three sections. The first being, we'll talk a little bit about dietary patterns, food insecurity, and health behaviors. dive in a little bit more about then how that food insecurity may be contributing to chronic disease in our communities. And then we'll conclude very briefly with those screen and intervene strategies, which based on the surveys that you shared back with the foundation, it looks like a lot of you are already kind of involved in these screen and intervene. So I guess it's good I didn't spend very much time on them in my presentation. So let's start with this first section of this overview of healthy diet patterns. So while it's definitely true that we cannot change our genes, at least we can't change them yet, we do now know that thousands of research studies have been published that have really shown that environment can either activate, dampen, or silence the way our genes are expressed. And whenever we think about environment, that includes things like things that are in the air that we breathe, maybe things that can be absorbed in our skin, and also even our social environment, those social connections that we make whenever we sit in a room with someone that we love, and how that can actually upregulate expression of positive genes, for example. Or when we're in a room with someone we don't really like, and we all know how that can affect our stress levels too. But food is also a major environmental input. It's something that's out in the environment. We chew it up, we swallow it, it enters our body, and eventually gets assimilated and becomes a part of us. So really, food is an environmental exposure that we all, if we have food security, usually are exposed to at least 3 times a day, 365 days a year. So we're now, really recognizing that food can play a big role in turning on genes, turning off genes. For example, some of the types of fats that we eat can actually increase pro-inflammatory signaling cascades in the body and contribute to chronic inflammation, which then can lead to a lot of the chronic diseases that we see in our patients. So the question that I get as a dietitian all the time, I teach medical students 2 years of lifestyle medicine in their first and second years of medical school. What diet is the best diet for health? And I've pretty much come to a conclusion that there's no single diet that's best for health. And most people in the scientific community would agree with me. However, what we do know is that there's really a general dietary pattern that can be very protective against a variety of chronic diseases. And really, we should be focusing on improving overall dietary quality towards that healthful dietary pattern, rather than focusing on individual specific foods like getting people to eat more pomegranates, for example, or adding more ground cinnamon to their food. We really should be focusing on the overall pattern. So if you actually were to sit down and look at all of the different medically tailored diets that we give for various chronic diseases like diabetes and hypertension, you'll actually find a lot more similarities than differences in those diets. Chronic inflammation is one of the primary pathways that link Western processed food dietary patterns to chronic disease risk and management. So a lot of the foods that or a lot of the dietary patterns that you'll see that help to protect against those conditions are anti-inflammatory in their nature. And so some examples that I have here, some of them you may have heard of, include things like the Mediterranean diet, the New American Plate, which is put out by the American Institute for Cancer Research as a primary cancer prevention diet, general whole food plant-based diet, as well as the DASH diet, which is commonly prescribed for patients with hypertension. All of those are dietary patterns that really share more similarities than differences, and they have all been shown to lower chronic inflammation in the body. And for most patients, whenever we sit down and evaluate what they're eating, it's going to require both an eat more approach, if I want you to eat more of certain foods to help improve the quality of your diet, combined with a cut back or eat less of some of the foods that you might be taking in a little bit too much of. And so again, this might be basic, especially if we have any dietitians or nutrition educators on the call, so I apologize. But generally what we're trying to do is focus on this eat more message of trying to get more color on plates, variety of colorful fruits and vegetables, dark green, yellow, orange, red, purple, blue, really teaching people to try to eat by color visually, half of your plate being fruits and vegetables. For proteins, we really do want those to be lean. The science says it's best to eat a variety. So in addition to lean poultry, moderate amount of eggs are fine. We'd really like to see nuts and seeds consumed at least once a day or every other day in a small amount, as well as beans and lentils and fish also being a regular part of diets rather than an afterthought. Trying to get more intact grains that haven't been processed, milled into flours. And then our fats are usually best consumed when they come intact. So avocados, olives, nuts. And if we are going to do oils, they shouldn't be high heat, deep fried oils. They need to be protected. Water, black coffee, tea. So what we do know is people who tend to follow a dietary pattern that looks like this, they tend to live 4 to 7 years longer than people who don't. And also the comorbidities that they experience towards the end of their life are a lot shorter. It's called compression of morbidity. So they may only experience complex health problems for the last few years of their life compared to having complex drawn out medical problems that consume the last 10, 20 years of your life. So we're really talking about not only prolonged life expectancy, but better quality of life for people that are able to achieve these kinds of dietary patterns. And the science looking at this adjusts for things like education, income, things of that nature, and still see these types of benefits. And I will add, if you have any questions as I go along, please throw them in the chat. We do have 2 other experts that are talking today, Christina Bridges and Sarah Downer, and they can probably actually answer any follow-up questions you have as we go along. So please put them in there. Also, that eat less message. What are we trying to cut back on? Anything that's white, almost. No, except for cauliflower. Cauliflower is very good for us. But generally speaking, we want to cut back on those processed foods, things that really were not part of the diets that our original ancestors would have consumed because they're really not compatible with our genetic makeup. So things like sugar sweetened beverages, even fruit juice, in large amounts are not something that generally we're designed very well to take in on a regular basis. Refined white flour foods, deep fried foods, processed foods, all of these have been linked to metabolic syndrome, diabetes, hypertension, cardiac disease risk, cancer risk, and even more recently, cognitive decline, which is a really big motivator for patients. We all want to have our full mental capacity with us, right? And so, trying to cut back on the amount of these is always also a good eat less message, depending on the type of disease that you're particularly concerned about. Perhaps it's a disease that runs in a person's family, and so they're really trying to reduce the risk. The amount of cutting back will vary on these things, but that's why you can usually connect patients with a dietitian to give a more tailored, medically tailored prescription there. So I have just a couple of pictures here just to kind of get us thinking as well about what really does shape behavior. So we know that you have to know how to prepare foods in a healthy way, how to identify them, things like that once you get home. But as we know from an ecological perspective, environment and resources do play a really big role in shaping health behaviors. And one of my favorite quotes is actually from a physician that we have here. And he starts a lot of his presentations off with the statement of decisions that people make are a reflection of the choices that they have. So if we really do an environmental scan of our patients' neighborhoods, of their homes, of their communities, what does that food environment actually look like? And there might be some healthy options that you could technically find in those environments, but if disproportionately there's a lot of processed foods, what might be characterized as a food swamp, a lot of convenient foods that are marketed at low cost, that also have a lot of, fat, sugar, things that make your brain feel good, it can be the natural default choice that people will have in that environment. In contrast, for communities that have lots of grocery stores packed with a lot of fresh food, you have a very different social norm that's communicated to those environments. This is a picture of Whole Foods. So not only do the fruits and vegetables at Whole Food always look very, very good, a lot of times there's specials that actually make where the produce is actually cheaper in these environments than they would be in an area that just has one grocery store. And then, the norm of the shoppers is everybody's putting these things in their cart. So you might be more likely to grab something fresh, whereas in another environment, you might not be. So a model that I really wanted to introduce before I get into the food security definitions is a model that was developed by a woman named Ellen Satter, and she was a therapist, a licensed clinical social worker, as well as a dietitian. She has since passed away, but her institute is still very rich and thriving. She's the woman who also developed the idea of eating competency, which is not part of our discussion here, but for those of you who work with patients and food, you might be familiar with that model. But I'm going to start trying to explain this with these two pictures on the left. So on the very far left, what do you see? You see something that's probably the very far extreme of that Western dietary pattern that I presented a little bit ago. So we have something that's very high fat, very processed, deep fried. We have white flour noodles with creamy cheese sauce, all of that. I think most of us could agree that if we sat down and ate that plate of food, our bellies would feel very full. We would probably feel a little bit of a stress relief, probably get some nice hits in the brain to help soothe ourselves. We may or may not get a bellyache later on down the road, but it was a rewarding experience while we ate it, right? In contrast, I have a very extreme anti-inflammatory, I guess, version of a dietary pattern. This probably more representative of like the raw foods movement, but what you have here are some zucchinis that have been turned into a noodle. So if you ever watch late night infomercials, you might have even seen those zoodlers being sold, right, on TV. So if it's on late night TV infomercial, I guess it's a mainstream enough. So we have two very big contrasts here. The noodles on the right are a great option. That's a great option for someone with diabetes. There's no processed flours in there, very low carbohydrate, calories very low. But it's probably not going to keep you feeling full for nearly as long, right? And the taste of those is probably more of a learned, a learned appreciation that can be acquired. But right now, a lot of Americans' palates are very habituated to this high sodium, high fat, high reward type of food. So keep those two ideas in mind. And now look over on the right side of this pyramid. So what Ellen Satter did is she basically took Maslow's hierarchy of needs, and based on her counseling experience with patients as not only a therapist, but a dietitian, she really created her own knockoff of Maslow's hierarchy of needs. And what she argued was that really what we're often trying to do for food is medicine. When we're trying to get people to use food in a particular way to improve their health, like medicine, to fight disease, we're really asking them to use food instrumentally. That is the highest ask that you can have of anyone. Forget all those other hardwired things in you that make you want to eat that fried chicken. But I want you to eat this food in an instrumental way. So what has to be happening underneath all of that first before someone can get to that point. And so she argued, well, first and foremost, people have to have their biologic needs met. So they have to have enough food. So if you think about those TV shows where people are dropped naked on an island for 21 days and they're like naked and afraid, like they have no food. And usually about the seventh day on that island, they'll pretty much eat anything that comes by because they're just really just trying to get some calories in them. But once you kind of hit that threshold and you have enough food for maintenance, then you can kind of be a little bit picky about what might be acceptable versus not. So maybe you wade through and say, I think I'll wait, and not eat that moldy piece of cheese or that slimy piece of meat. I'm going to wait until maybe I can find something that is a little bit safer in those regards. And then eventually, once resources are a little bit higher, that's when people have this reliable, ongoing access to food, and they're not necessarily worried about eating something that might give them food poisoning or about not having any food at all to eat. And so that's really the definition of food security. So food security, the definition USDA is that it occurs when all people at all times have enough food for active, healthy life. Healthy life here is just defined of preventing, malnutrition. We're not really talking about treating disease in this context. It includes at a minimum safe availability of nutritionally adequate and safe foods, assured ability to acquire acceptable foods in socially acceptable ways. So we're really talking about this middle part of the pyramid whenever we're talking about food security. What we often are asking patients to do is to go even a couple levels above that. So they have to be food secure first as a foundation for behavior change. And only after that food security is there, might we then be working with them to maybe learn new ways to cook medically tailored foods in a way that tastes good to them, maybe introduce some foods that they've never had before that would be considered a novel food, and then eventually getting them up to that pyramid of eating more instrumentally. So it can be very, very useful whenever you're working with patients and with populations of really thinking, where do we think people are on this pyramid? Where might we want to intervene? And what's a realistic expectation right now? And how can we plan for the future? So in contrast, what's food insecurity? Food insecurity, I've tried to draw this little arrow out here. We often, try to dichotomize it as they're food secure or they're food insecure, and that's that. But in reality, it operates on a spectrum. And just because a patient is classified as food insecure, that doesn't necessarily mean we know about the severity. And it's important to really drill down a little bit more to understand where they are on that spectrum, because that's going to dictate what their nutrition needs are and what their intervention points probably need to be. So on the left side, we have this idea of food secure, but there's actually an initial phase of people having some, maybe they're worried about paying a bill, or a new medical cost has come up, and so their resources are a little tight, where they might just psychologically start to worry about being able to buy groceries for their family. Their actual dietary intake has not changed. It's just the presence of the worry is there, and that's called marginal food security. That's actually a really important concept that oftentimes gets ignored in national studies, because marginal food security actually gets categorized as food secure in USDA research. So it's an experience that's somewhat ignored. The problem with that is marginal food security, where people only report worrying about their food, is very predictive of mental health issues. For pregnant women, it's predictive of gestational diabetes risk. And so that might represent a population that you might have ignored or not really realized so much is fully food insecure, but they're already starting to experience some consequences of that instability. As we go along the spectrum, and we're using the USDA definition, which I've included here, of this limited or uncertain availability of nutritionally adequate and safe foods, or limited or uncertain ability to acquire acceptable foods in socially acceptable ways. So what we see in the brighter yellow box is this term called low food security. And that's where people start reporting reduced variety in their diet. Maybe they're eating a lot of boxed cereal, for example, or a lot of pasta or a lot of rice because those things are cheap. They were able to get them at a food pantry, and that's the food they have. And so they're actually meeting their calorie needs because of the foods that they are eating, because they're usually more processed foods, because processed foods are cheaper. They actually might be eating more calories almost on accident than if they were food secure, because the lower calorie items like fruits and vegetables are not, they're a luxury item whenever you're in this category. Whenever you jump to the red bar, that is usually this term hunger, of very low food security, physical reports of hunger, not eating meals, skipping meals, losing weight because there wasn't enough food in the house. So very different degrees of food insecurity happening. And if you think about disease self-management, like diabetes, for example, the people in the red are probably going to be those that are more likely to have hypoglycemic episodes at home, much more than the people in the yellow. But if you're not looking at it at that type of spectrum and you're just calling them all food insecure, and you can't explain that population to a little bit more granular detail, you might miss something that you might want to consider as part of your intervention. So the prevalence of food insecurity, these are all pre-COVID estimates, and I kind of did that on purpose because I wanted to be able to talk about the different disease conditions in here. And so I was trying to do apples to apples, snapshot in time. But pre-COVID, about 13% of US households were affected by food insecurity. If you drill down to adults with diabetes, that increases to 20%. If you further drill down and look at people with diabetes who don't have their diabetes in control, that increases to 1 out of 4 people in that population having food insecurity. If you look at households that have at least one adult who has some form of a physical disability, that's between 22 and 33%. And shockingly, up to 70% of people accessing mental health services, the literature suggests they're experiencing food insecurity. And sadly, this bottom population really has not had a lot of intervention work done. And so that's a really important opportunity, I think, as we move ahead and plan forward with this. So this was a model introduced by Hilary Seligman and Dr. Schillinger in 2010, and we'll provide you with a copy of this article actually for your reference after the training today. But it's a really nice conceptual diagram of how food insecurity can really be both a cause and a consequence of poor health. And if you start at the top of the figure here, you can just think about, okay, I've identified a food insecure individual. What's actually happening? What do I know is happening for this person? Well, by definition, there's constrained choices whenever we don't have a lot of resources to buy food. By default, people will tend to pick foods that they know will keep them feeling fuller longer and that they can afford. So those are usually more energy dense, higher fat, higher sugar type items that help them to feel satiated for a longer period of time. We also know by cost, fruits and vegetables are usually the first thing to go out of the food budget. Those foods that people do tend to eat are usually a lot more processed, and they tend to have a higher glycemic load. And food insecurity operates cyclically. Not only does it happen cyclically during the year, so for example, during very cold months when utilities go high, very hot months when utilities go high, that's usually when you'll see food insecurity rates go up. So we have a cyclical during the year, but also food insecurity can happen cyclically during the month. So we have food resources for a couple of weeks, and then we don't have food resources for the remainder of the month. And so what we see is that whenever there's not a lot of resources, there's skipping meals, lower intake of calories, and then whenever food is available, there's that tendency to overeat. And metabolically, this is the exact same thing as what you would see in someone who yo-yo diets to lose weight for, looks. So you restrict calories for a couple of weeks to fit into those pants or that dress or whatever, and then you totally go off that and you go back to your regular and you gain all your weight back. What that does is that really harms the metabolism long term. So you're set up to keep gaining weight a lot faster and a lot easier than someone whose calorie intake is more regular. I had a qualitative study that I did trying to understand this dynamic because, logically you'd be like, oh, well, you should just eat, you should stretch that out and, try to balance it out. So maybe you only moderately, have what you want for all month so that you won't have these periods of deprivation. And one person's quote just really stood out to me. He said, whenever I get my money for the month to buy food, I just want to feel human again. I just want to be able to have a full meal and feel fed. And psychologically, that's what he did to cope with the remainder of the month when he knew that things would, be more tight. So we also have stress that happens during, all of these cycles, and that's what predisposes people to obesity, hypertension, diabetes. And then as those diseases progress, healthcare costs go up, much more difficult to manage those conditions. So they continue to get out of control, might become disabled, may not be able to work as much, lower income contributes to more food insecurity. So you can really think about that as a vicious cycle. So what are the consequences then of food insecurity and chronic disease? I'm just going to start off with obesity because obesity contributes to so many other chronic health conditions that we see in the clinic and in our communities. I will say that the literature primarily supports a relationship between food insecurity and obesity in women. And the reason for that, we think, is because women disproportionately bear the consequences of food insecurity. They will be the first ones to restrict intake or eat something, more processed foods and save the fruits and the vegetables for their children, for example. So you see a wider disparity in how their dietary quality is impacted whenever they're living and trying to manage a food insecure household. But not only do we know there's limited access to healthier foods, which tend to have less calories. We've talked about that almost what's like a yo-yo dieting, so that can pull the metabolism down as well. There's also a lot of stress, anxiety, and depression. So those cheap foods that are available, 50-cent candy bar, can really help to temporarily, lower some of that stress, those stressors. Just like I'm sure everyone here has eaten a cookie once when you didn't want the cookie for any other reason but you had a bad day, right? So those mechanisms are here within all of us. Additionally, what's really interesting, not surprising, if you don't have as much food to eat, you're less likely to be physically active through leisure time physical activity. It takes a lot of energy to walk around the block for entertainment or for your leisure time if you don't have enough food to eat. We also know that there's a very strong relationship between sleep and obesity risk. So people who sleep less, they have a higher risk for obesity, and food insecurity is associated with sleep disturbances. So there might be that mechanism at play. And all of this can really lead to chronic inflammation and insulin resistance, which makes the body more likely to store fat. So a lot of complicated, complex pathways that are going on here and how food insecurity can contribute to obesity risk. Also, food insecurity and physical disabilities are very correlated. And people with physical disabilities also tend to be overweight, obese, possibly because of their physical limitations, but there's also some structural inequities too that contribute to that. But what you can see here is that as disability prevalence goes up, and I've pointed to Kansas in there, as disability prevalence goes up, so does food insecurity prevalence. So you also, for some people with food insecurity and obesity, you also might have a physical impairment, mobility limitation that may be having a role to play here as to why they're at a higher risk for obesity. So chicken or the egg, I'm moving on to my next health outcome, depression and food insecurity, which comes first. A lot of people thought that, that food insecurity was really more of a consequence of depression. So if I'm depressed, I'm maybe not going to work as much, my income goes down, I may not feel like preparing a meal or going grocery shopping, you know, all those reasons, and then therefore I might be food insecure. But there's actually been some cohort longitudinal observational studies of women who were living in a food insecure household, none of which had depression at the time. And over time, seeing that food insecurity actually is a pretty good predictor of depression risk, at least in women. So there's most likely a bidirectional relationship here of they're both contributing to one another. We do know that consumption of ultra-processed foods can contribute to the severity of depressive symptoms. And there's actually been some nice little studies that have come out more recently showing that if you add fruits and vegetables to people's diets who were not eating them before, that can actually improve feelings of well-being as well as feelings of happiness and life satisfaction through the addition of those things. There have also been some randomized control trials that show anti-inflammatory diets. There's two studies that I'd recommend you look at. Both one's called SMILES, the other one's called HealthMed. Do not ask me to tell you what they stand for because I cannot remember. But those dietary patterns were shown to reduce depression symptomology among people with serious mental illness, and also to improve significantly the odds for remission among people with severe depression. So we see a lot of really exciting new literature about these anti-inflammatory dietary patterns and removing those ultra-processed foods from the diet, and that really being able to have a good impact on mental health. So I'm sure almost everyone on this call has some patients with diabetes that you work with either directly or indirectly, because that is, you know, a really big contributor to healthcare utilization. And I just have a couple of mechanisms that you might want to think about on how food insecurity might be contributing to the problems that you're trying to tackle when you're managing these patients. So food insecurity, let's start kind of with hyperglycemia over here. There's 6 possible ways that food insecurity can make those numbers really try to stay high. One, we've talked about higher intake of processed foods relative to unprocessed foods. Those foods metabolize a lot faster. They can make blood sugars, especially after meals, go up. We've also talked about binge fast cycles, so not having very much and then you overeat whenever food does become available. Medication and food scrimping. People cutting back on insulin, cutting back on medications, oral medications for diabetes control, because they're trying to afford both food and medicine and they don't have enough money for both. So they'll cut back on the medicine to be able to buy enough food to eat. So they'll be underdosed on their meds. Chronic stress, we know contributes to insulin resistance and can also cause hyperglycemia. We know that people with food insecurity have reduced sleep quality. There are studies that show that just one night of sleep debt can increase insulin resistance in the body. It's a very strong effect that can happen. So if people are not getting good quality sleep because of stress or other things that are going on in their life, that will directly physiologically contribute to their insulin resistance. And then also those lower rates of physical activity that we know go on, that also contributes to insulin resistance and diabetes. In terms of hypoglycemia, you could probably guess these mechanisms. Skipping meals, not eating meals for a full day can cause low blood sugars, as can not having enough carbohydrates. So this would more so be applicable to someone with very low food security, someone who really just does not have enough energy calories throughout the day and are skipping meals. They might accidentally take too much insulin, or some sulfonylureas can cause a big blood sugar drop if you don't have enough carbohydrates around. That timing as being a potential way. The American Diabetes Association has some really nice guidelines that you can reference in how to better manage your patients with diabetes and food insecurity. And there's also a very excellent resource that's called Clinical Management of Food Insecure Individuals with Diabetes that I have on this slide. So if any of you are directly working with that population, I'd highly recommend that article. So we're kind of winding down on our review here on the chronic diseases, and so I wanted to introduce this blood pressure, because that's also a very common thing, and oftentimes they go hand in hand with diabetes. And I want to first say that the U.S. population in general, food secure or not, have terrible adherence to the DASH diet. And actually, since the DASH diet was introduced and found to be an evidence-based way to lower blood pressure, you would think that maybe people on a population level would be more adherent to DASH as they learned about it, but actually the adherence rates have further deteriorated. So generally speaking, as the US population, we do not follow DASH. And so that's one of the reasons why it can kind of be hard to say, well, does food insecurity play a role in chronic disease or in hypertension risk? Because we're all eating terribly in that regard. But what we do know is that food insecurity does increase a risk for low intake of fruits and vegetables, as well as low-fat dairy. We also know that some micronutrients such as calcium, potassium, and magnesium, which are parts of the DASH diet, are lower in people who are food insecure. And more recent studies have looked at food insecurity. It may actually prevent people from being able to apply that new knowledge about how to manage their blood pressure. There was a really interesting study. It was a small study published by the CDC in their journal, and they identified patients with diabetes who had poorly controlled hypertension. And they enrolled these patients in a study where the intervention was giving them blood pressure monitors to use at home and teaching them how to self-monitor their blood pressure. They asked them to do that 3 times a week, twice a day, and the readings were sent and integrated with the clinic so that the clinic could also help with that monitoring. And then they also received some education on how to manage blood pressure through lifestyle change. And at the end of the 6 months, what they found is that people who were food secure at the start of that intervention, their blood pressure dropped by 9 points, systolic blood pressure, while those who were food insecure, their blood pressure unfortunately went up 3 points over that 6-month period of time. Both groups, the food insecure and the food secure groups, adhered to their medications equally, and there were no difference in the blood pressure monitoring. So both groups were trying. Just like the patient I told you about at the start of my presentation, he was trying, but there were things that were getting in the way of the food insecure group actually being able to lower that blood pressure. Some of you, most of you might be familiar with the Map the Mule Gap resource. I wanted to just have that be available in case you had not yet viewed that. This is just an estimate for Kansas, looking at food insecurity rates in the state. In 2019, it was estimated that nearly half of people in Kansas do not really qualify for food assistance programs because they're really above that income eligibility threshold. So that would represent the population that really food pantries, food banks, clinic-based food assistance, that's really the only place that they can go to get food resources support because they don't qualify for SNAP. And then more recently, there's been an interactive Tableau site sponsored by Feeding America. And what you can actually do is you can go and estimate the healthcare costs attributable to food insecurity in your particular county. And so that can be really insightful to see, gosh, if we could intervene here, how might we be able to lower healthcare costs in our system? And those costs are based on healthcare costs estimated for inpatient and outpatient excess costs for food insecure patients, as well as emergency room costs and prescription med type costs. So as we wrap up, again, kudos to almost everyone on this call. I think you're already doing some screening in one way or another for food insecurity. I have just the 2 item here that's been endorsed by the American Diabetes Association, as well as the American Academy of Pediatrics, as well as the AARP too, I think. So it's asking patients if they worried their food would run out before they got money to buy more, and did the food they bought, it just didn't last.
So they're not part of our,
have enough money to buy more.
Maybe you can
and typically these things are administered by a healthcare worker in the setting, but it doesn't have to be a physician. It could be a nurse or someone else within that healthcare team. And it's really important that we normalize food insecurity as part of a screening interview process. So it could be something like, saying many of our patients, have reported that, they don't have enough food to really follow a healthy diet. So I just want to know if that's, something that's going on for you. I'm going to ask you 2 questions. So really asking this question to everyone and not singling people out. Because oftentimes people in that more middle income band might even have private insurance. If they're having a lot of complex medical issues, they're actually at a much higher risk for food insecurity, and they may be hiding it very well. Or, it may not be on your radar, but it might actually be something that's truly impacting them. So these are 2 figures developed by Feeding America a couple of years ago, just trying to visually give us an idea of where we can go with this. We can start with a clinic to community model where the clinic is doing the one conducting the screening. There's an option for them to have a referral, good working relationship with their food bank and maybe some surrounding food pantries where they know those food pantries actually offer not only food assistance, but food assistance that might be appropriate for diabetes or hypertension, so that patients will actually have something that can be helpful health-wise for them. That healthcare site might decide to take on a new healthy food distribution program, which could be like an on-site pantry, which are now commonly called to as food pharmacies more often. They could do mobile food distribution. They might have some emergency boxes that help to just show people how to follow a diabetes diet, but they're not getting ongoing assistance. And then there's also the connect with long-term food resources support that can be done here. In contrast, what's not utilized as often, but what I think can have such a profound effect on population health. And I want to commend, I think there are some people on the call today that are already actually doing this in the feeding sector, but really starting at the pantry and recognizing that people who come to pantries are oftentimes very medically complex people who may not be getting any medical care at all, and using that pantry as the source of medicine also for other medical needs. So not only can that pantry provide healthy food and wrap around nutrition education and support, but maybe they can bring in clinical partners that do health screenings, like screening for diabetes, screening for hypertension, and then facilitate some connections with health insurance or indigent care that can help meet those needs that were identified in the pantry space. So that is our quick overview, and I will stop yakking and turn it over to the next speaker.
All right, well, great. Thank you, Dr. Wetherill. That was a fabulous presentation, a quick presentation, but jammed packed with a lot of information that I think we all need to know, and sets a really great foundation for our ongoing conversations today. Just so many moving parts for us to think about as we kind of engage with this work. And there's been a lot of conversation in the chat, which has been great. The other speakers for today have been able to jump in and answer some of those questions that have been coming in, but keep those questions coming. This is our time to engage with these experts from across the country on these issues. So if you have questions, if you want to unmute yourself, go ahead and do that and ask your question. If you want to put those questions in the chat, we'll monitor that as well. I'll stop talking here for a minute to see if anyone has a verbal question they'd like to toss out. Well, everybody's kind of getting their juices flowing here mentally. I will toss out a question. As somebody who's not a dietitian, obviously, you know, eating seems so simple when you're doing it, but when you start having to pay attention to it, it seems overly complex at times. You know, when you're helping patients who have really had to really think about just where their food is coming from, not necessarily even their caloric intake or the quality of their food, how do you start working with patients who are kind of starting at that point in the process?
I think that's a really good question. I think it's important to be really cognizant of the recommendations that you make, because you don't want to contribute to the stress that they're already having. So I will not make a laundry list of all the things that they're doing wrong, because that just adds something else on their plate that they can realize, oh, great, this is all these things. How on earth am I going to change all of these things? And it may not really be in their control to change all those things. So I usually will start with kind of like the low-hanging fruit. I'll ask patients, like, what do you, of all the things that you're eating, what do you think is helping your health, and what do you think is harming it? You know, and let's maybe allow that patient to direct you to where they want to go and where they feel the most ready to change. And for everybody, that's different. If I could wave a magic wand, I would get everybody to stop drinking sugar-sweetened beverages, because they cost money. They are not helpful for anything. They're trash. Like, as a dietitian, like, they are not good. But in working with lower income families, what I've learned is that, you know, sometimes that's the only thing that a mom can afford. And that's a sweet treat they can give their child to help not only, you know, just make them a little bit happy for a little long, but that carbonation in that sugar sweetened beverage makes them feel full. So you really have to think about that true ask that you're presenting, and just really do it in a very informed way. But if you allow the patient to lead and build on those small changes, that's where I would encourage people to start.
Great. We had a question in the chat, and the question is, how do you address behavioral changes in individuals that may have a history of food insecurity but are no longer food insecure?
Yeah, that's a really good question too. I think a lot of people have experienced food insecurity in their past, whether they realized it or not. I can recall back in college, I was food insecure and didn't realize it at all. The only thing I could afford was like a $1 thing of rice from the Chinese restaurant, you know, on campus. And so I would like literally eat an entire thing of rice with soy sauce on it. And that would be my lunch. So I think allowing the patient to like tell their story and creating space within a within the encounter for them to explore their relationship with food and why they're eating the foods they're eating and when they're eating the foods, and sometimes giving people not only a food diary, but doing some self-reflection journaling can be really helpful of like what their emotions were at that time. There is a really excellent curriculum that I love that has been developed by Leah's Pantry. It's called Leah's Pantry, but it's a trauma-informed nutrition curriculum. And so it's really designed for people that not only maybe have experienced food insecurity in the past or at present, but also other forms of trauma that may be influencing their food intake. And so that's a really, really nice curriculum, and they have some training that you can do if that's something you'd like to learn more about.
Brandon, I have a question.
Yeah, sure.
Yeah, so I want to preface mine with the same thing that Brandon just said. I am not a nutritionist. I have a clinical social work degree, so that's my background. But it feels like one of the challenges when you're working with people on these behavioral changes, lifestyle changes that you're talking about, is doing things that are just totally radical for where they're at in the moment. So talk about making these big changes. And so when we think about nutrition, it feels like maybe one of the things you've talked a little bit about is how do you start making changes? Like if they've eaten certain foods or used to doing things in a certain way, how do you begin to modify? What are the easy ways of kind of getting in there that you talk about, the low-hanging fruit, and maybe modifying what they're already eating or how they're already eating and making those changes so that that's maybe a little bit more sustainable for people as they get going, and that idea of incremental change in that versus just an initial, this is how you eat and we're going to radically overnight just shift that and this is how you need to eat.
So one of the questions I oftentimes get from physicians is how many units of referral should I give for a dietitian? And I say, well, how many units or how many visits do you usually do when you write a PT referral, a physical therapy referral? It's usually like 12. So don't send me a unit referral to see a patient and think I'm going to be able to change everything, because that's not normal. Like nobody, I think, can transform themselves. I want to just reiterate, you always start where the patient is and don't assume about their level of readiness. Or because some patients might actually be a lot more ready, it just may be the resources that are in the way. There are plenty of people that have tons of resources and all they can handle is like a little bit of incremental change. So spending that time to really gauge where that patient is and not make any assumptions about them. There have been some really interesting studies that have shown that actually people that try to take on multiple health behavior changes at once in various spheres, so like sleep, diet, and physical activity, that sometimes that can actually be more successful than if they just try one change at a time, because those behaviors reinforce themselves. So I don't think I can easily answer this question, but I would just
one easy answers.
No one easy answer. But I would just say you got to know your patient well, and you also have to know your population well and the resources that they have and the right combination of that.
All right. Well, the questions are flowing in now, and I think we're going to have plenty of time for Dr. Wetherill to answer those in the chat. That chat function will still continue. I think one of the, probably a quick question here is, there was a question about what was the outcome of the patient that you discussed at the beginning of your presentation. I think that was the cliffhanger.
I will say that patient was a loss to follow up at the end. He was living in a single room occupancy. His family had disowned him. He had no social supports outside of the agency. And it was not the outcome that I had wanted. And I think that is why it was so pivotal to me. I was sick of working with people one at a time and I wanted to change systems. So for the benefit of that patient in the long, and other patients like him in the long run. So that's why I share that story, because oftentimes we all have that one experience where we're like, this is not okay, and I'm going to change it. And I really believe everybody's here on the call today because you've had an experience like that. May not have realized it yet, but I have faith and trust that we've all had that experience. So.
Well, thank you again, Dr. Wetherill. I know you'll be here this morning. You can review the chat as you take a break here from presenting and look at the questions and the conversation. Great conversation. Virtual round of applause for Dr. Wetherill this morning. I'm now going to turn it back to Elizabeth for introduction of our next speaker.
Yes, thank you again so much, Dr. Wetherill. And thank you to everyone for your great comments. You will be rewarded for that by the fact we're taking away your 5-minute brain break so we can roll right to the next speaker, but you will get a break after that, we promise. So even though she is not from Oklahoma, so I can't say hi y'all to her, I am very pleased to introduce our next speaker, Miss Sarah Downer. She brings another very exciting perspective to this conversation, that more of the research and the policy implications. Ms. Downer is the Associate Director of the Whole Person Care Initiative at the Center for Health Law and Policy Innovation at Harvard Law School. Got to take a breath after that. Like Dr. Wetherill, she is also an advisor to the Food and Society at the Aspen Institute's Food is Medicine initiative and has played a pivotal role in creating the Institute's report on this subject, scheduled for release in early January 2022. You have our word that you will get that hot in your inbox once it is released, and you can feel very satisfied today that you are hearing the first in Kansas to hear about this exciting report. So take it away, Sarah, and thank you for joining us.
Thank you so much. What a privilege to be here. I'm gonna put my slides up, and I know that you guys are skipping your break. So anybody who needs to like get up and like move around while I'm talking, please feel free to do so, because I know that this is a lot. First of all, I want to thank Dr. Wetherill for setting this conversation up so perfectly, because I think she did an incredible job of laying out the science for us on why this matters for the healthcare system, and really making the case for why the healthcare system needs to come to the table in a really robust way to make change in this space. So that is what the Center for Health Law and Policy Innovation is all about. We are let me just grab my slides here so you can see them. Hopefully everybody sees the right screen. Okay, so we are a part think tank and part nonprofit law firm that's at the law school. So I have a team of about 20 lawyers. All of our work that we do is mission driven. So we are all about improving access to healthcare and the comprehensiveness and quality of that healthcare for people living with chronic illness or who are at risk for chronic illness. And within that sort of mission, we've built a whole food as medicine portfolio. And the reason that we did that was because we used to be exclusively a direct legal services law clinic for people who are living with HIV/AIDS. And so it was formed in the late 90s. And we were doing a lot of estate planning, health advocacy for people who were passing away very quickly. And as we continue to work with people who are living with HIV, our clients were living longer. We started to do policy work because we were seeing the same issues come up over and over again, right? So Marianna talked so beautifully about the individual experiences that you have that lead you to want to do systems level change. So that's exactly what we saw. And so we were a HIV policy focused center for a while. And why it becomes so obvious that nutrition is a critical piece of healthcare is because there's a uniqueness to the HIV space in healthcare, which is that the Ryan White AIDS program, which was founded to sort of help support healthcare access for people with HIV, help support medications and getting access to care. It also had a funding stream for ancillary services like nutrition, like housing support, all these wraparound things things that people with chronic and complex illnesses really need in order to manage their disease and to thrive. And so from the very beginning, there was funding in there for nutrition. And so a lot of the sort of early innovation in the food as medicine space, at least the one that we work most closely with, were organizations that were funded by these federal dollars to provide nutrition support to people with HIV. And so initially it was, maybe organizations that were in church basements making comfort meals for people that were, wasting and isolated. And then over time, of course, their clients started living longer and longer and having lots of complex medications that were making it possible for them to live full and happy lives. But also have a lot of side effects. And so managing side effects through diet was important. They also over time started to get things like diabetes and cancer and other things, right? So they became even more medically complex. And so the organizations that we were working with, which provided medically tailored meals, started to really specialize in being able to design nutrition for this population. And some of the sort of earliest research was on these very health compromised populations that were receiving nutrition services and how positive that was. So that's the background that we have. Is we worked with lots of nonprofits in the space that were providing these medically tailored meals. And as we transitioned to do chronic disease work across the board, we also started to see the benefits of those meals for people who didn't have HIV, right? Who had chronic disease or were undergoing cancer treatment or have MS or mobility challenges and sort of need some extra nutritional support to manage their disease or to prevent some of the effects of chronic illness. So that's the space that we come from. We are focused on integration of nutrition services into healthcare delivery and financing. And so that's what we work on every day. And what we want to be able to do is give providers the tools that they need to be able to connect patients with the services that will help them to live their best lives. And we know that nutrition support is critical. Dr. Wetherill really made that point very strongly. So that's what we do. We have partnered with the Aspen Institute Food and Society program. Aspen is a think tank, and we are working with them to produce the Food as Medicine Research Action Plan. So this is about thinking about, now that we know all of this information that Dr. Wetherill's presented, what do we do about it in the healthcare space? And not just what do we do about it on the ground, which there's so much innovation happening on the ground. So, and you all are about to be a part of that. But what do we need to do to change our systems to enable that innovation to be available to everyone who needs it in the way that they need it for as long as they need it, right? So that we can really see the benefits of our understanding of the link between nutrition and health in our healthcare system, on our outcomes, both individually at a population level, and then to the healthcare system in general, right? So we focus in the Food as Medicine Research Action Plan and in our work on food as medicine interventions defined in this way, which is all of these programs and services that are going to either provide actual food or support for purchasing those foods, the foods that support health, and have a nexus to the healthcare system in some way. So that's how we scope it. There are a lot of things that are outside of this definition that matter a ton to whether people are able to have foods that support their health. We scope it this way so that we can really be concrete and specific and make true change at this intersection so that we can really kind of move on specific points. And also, we just want to ensure that we are doing what we need to do here at the center. The healthcare system is extremely complicated, right? I mean, you all work in it, the roster of this event looks exactly like my client base. I work with lots of nonprofits. We work with food banks. We work with nonprofit meal delivery organizations. We work with departments of public health, people who do SNAP Ed programs, people who do WIC nutrition education programs. We work with those individuals and groups. We also work a lot with community health centers. We work with health systems, their community health and engagement teams, trying to think about what are they going to do with the information that we're rapidly learning. And the healthcare system is so complicated that we want to be able to give them, to help change happen in this small sphere, which you see here on the screen. And why is this hard? I think is a question that, you know, we come up over and over again with, because we have some intuitive sense that, you know, people who don't have enough food or enough variety of food or the foods that support health, we need to do something about that. We've known that for a long time. People have been trying to do things to combat this for forever. The healthcare system has not been designed for services that support folks outside of sort of traditional clinical care. And so when we think about the interventions that address health-related social needs, we understand more and more these are the things that are driving what people see in the clinic, right? It's nutrition insecurity, it's housing, unstable housing, it's all of these things, lack of transportation, right? That's driving a lot of what is then manifesting in the clinical space. The healthcare system has never been designed to address these things. And so if you think of it as, you know, a house, right? It's a house that's been built. What we're trying to do is retrofit this house to fit all these things in there. And we could do it and do it well if we really sat down and thought about how it's going to happen in a really deliberate way. But we're not doing that. And that's because there are all these sort of locks on the door, right? Like if you're going to have new guests over to your house as a healthcare space, think about it as you as a person. If you're going to invite people over to your house, you make sure that the walkway is clear. You think about who's going to sit next to each other at the dinner table, and you don't put two people that aren't going to get along next to each other. You think about, you know, okay, how's this flow going to work? Where is everybody going to be? Is it going to be comfortable for them? Right? We're keeping the door very much closed. And so the healthcare innovations that we have are having to kind of climb into our system of payment and delivery through the windows. And that's an awkward fit, because what happens is you end up in somebody's bedroom and you're only there, right? So like you're only available to this particular group of people who have this diagnosis and are paid for by this Medicare Advantage plan, and that's it, right? Whereas everybody could really use some of that, or at least they could use assessment for that and really good, thoughtful treatment about, you know, well, maybe an intervention will work if it's nutrition plus transportation, right? Like we need to be thinking about this, and we're not. A big part of that is lack of research, right? So we want to know what works and for whom and for how long, because this is hard. And we want to get it right if we're going to spend the time and the money to integrate these things. And so this is what my understanding of, you know, this gathering, this is what this is all about. This hard thing that we all want to do, and how are we going to do it? And that there's going to be a planning process for how this is going to be done. So necessary, right? Because we have this crazy house that doesn't ever open the door to these interventions. So we need to really be thinking about it. Right. And then there's also this, well, is it healthcare's job to do this? Because we have this whole system, right? We've got SNAP, we've got WIC. We have a sort of robust network of food pantries across the country that are doing amazing work. So should it be healthcare's job? And I think Dr. Wetherill has made the case extremely clearly that yes, we need to be at the table, healthcare, in a very strong way, because it is partially the job of healthcare if we want to see, you know, people's outcomes improve. If we want to see more cost-effective healthcare, we need to be engaging with these ideas. And then there's confusion about services. We're going to talk a lot today about what food as medicine models are emerging, what kinds of interventions, what they look like. But this is a very dynamic field. There's tons of innovation happening. Nothing is set in stone, which is very exciting. And it is very, I think, anxiety producing for the healthcare space, right? People are like, I just want to know what it is that works. I want to take it off the shelf. I want to give it to my patients and get the results that I've been promised I'll get. And that's kind of not how this space works yet. So we're all in this room innovating and changing the landscape and the way that policy works. The best kind of policy is made by taking the best on the ground experience and feeding it up into good policy. And that's what we really want to do here. We want to make sure that we're doing activities on the ground that are going to inform good policy making, as opposed to the policy making up here coming down to the ground in Kansas or any place and being an awkward fit with what you're actually needing to do with patients. And then there's the but what about, right? If you do food, what about housing? What about transportation? What about all these things? We need to, obviously we need to start somewhere, but there is also a lot of reason to absolutely put the need for food and food insecurity in the broader context of your patients. And in fact, if we don't consider that and put it in the broader context of your patients, we are not going to get translatable results of the efforts that you are going to engage in, right? So yes, but what about is a great question, but the healthcare system, again, is so complex that when we change it, we need to really be thinking about, okay, specifically, we want this to happen. Let's allow this to happen. Let's step back and consider it in context and make sure it doesn't preclude any of the other things we want to have happen. It's complicated. The programs on the ground are part of making sure that these solutions are comprehensive. And then there's a lack of infrastructure. So the screening that we just talked about, that is part of the infrastructure that we need to make sure people can get access to food as medicine interventions. So it's happening, it's developing over time. People on this call are part of that, which is extremely exciting, but we're still developing. We're still sort of building this plane as we're flying it. So, about 10 years ago, 10 years ago when I started in the food as medicine space in a robust way, the models for the interventions that you're about to hear about, produce prescriptions, medically tailored meals, medically tailored groceries, food pharmacies, they didn't really appear in any government documents anywhere, right? So this was a sort of fringe idea that lots of people were behind, right? People have been working on this forever. They've known that nutrition and health are absolutely linked forever, but it really was this case that we would, my faculty director has lots of relationships from his HIV advocacy days with Medicaid directors. And he would go to the Medicaid directors and try to talk to them about medically tailored meals or food as medicine. And they would say, please do not, just don't talk to me about food. I like you a lot. We're not going to have a conversation about food. It doesn't belong in this space. And the conversations have absolutely flipped, only so many years later, where we're being invited by these same people who are like, do not talk to us, get out of this room. We love you, but no. I have completely flipped to being like, yes, we want to hear what's going on in this space. How is it being done? How can we do it? And, we're still a little anxious about it. So what do we need to be thinking about moving forward? It is a completely different conversation. And there's been so much progress made on the policy front. And so the innovation on the ground, there's so much happening on the ground in this space. It is absolutely ahead of the research and ahead of integration for sure, but there's so much happening, right? So it really starts to sort of have a tipping point in around 2014, where the Farm Bill dedicates $100 million to produce incentives. And they say, you can also do a produce prescription design with this, where you really are sort of linking these produce incentives to healthcare in a formal way. And then there are big changes at the Center for Medicaid and Medicare that start to happen. And then in 2018, you've got the House of Representatives and Congress setting up a food as medicine working group. You've got states setting aside millions of dollars to do big demonstration pilots in the state, lots of flexibility introduced into Medicare Advantage. So this starts to really roll. And then in the last 2 years in particular, we are absolutely off to the races. So now we have federal legislation. We've got legislation in multiple states. States are setting aside money from their budgets to do demonstration projects to make sure that these services can be brought to more people. And we've got lots of federal agency actions. So the National Institutes of Health committing research dollars to researching food as medicine. We've got folks proposing produce prescription programs for the Indian Health Service and within the VA. So just lots and lots and lots of activity across the government. So across states on the legislative side and the administrative side. Very, very exciting. Lots of it has been proposed and not passed, but lots of it has also been actually sort of money that was appropriated, and now these demonstrations are up and running. So just a ton of activity in this space, which is really exciting. And then, you know, so Dr. Wetherill showed you the hierarchy of need pyramid. This is another pyramid because I think we all liked the smart art pyramid when it first emerged. But this is another pyramid that we use to kind of illustrate the models that you're going to see and hear about today. So these are the big emerging models in the food as medicine space. And like I said, it is a very dynamic space, so nothing is set in stone, and these categories do bump up against each other in really interesting ways, and we'll talk a little bit about that later. But, you know, at the bottom of everything, right, we've got our robust, hopefully robust social safety net of federal programs. So we've got our emergency food and anti-hunger social service programs, SNAP, WIC, school food, all of those things. That needs to be in place if we're going to build on top of that for food as medicine, unless something else happens to fundamentally shift the way that we support food or the amounts of resources that people have in their pockets. Because those programs are necessary. The rates of food insecurity that we see, the rates of nutrition insecurity, you know, all of that, that is despite all of these programs. So we even need to sort of make sure that people are participating in these programs as much as they can. And then we need to build sort of more on top of that if we're going to really have an impact on health outcomes in this space. So that's at the bottom, right? And so we know that those funding streams are non-healthcare funding streams, but they need to be robust if we're going to then build healthcare stuff on top of it and see an impact. So you can see the priorities for healthcare funding are here. And so we have these produce prescriptions and vouchers. So the way that this pyramid is set up, it's by level of intensity of the intervention, meaning kind of the amount of food that's provided, right? And the population that we imagine would be eligible for this. So we've got produce prescriptions. Those are less intense in terms of the amount of food that is provided or supported, generally speaking, and probably appropriate for more people that are, you know, either at risk of a chronic disease or have a chronic disease, and they just need that support to be able to introduce fruits and vegetables into their diet or sort of key parts of the diet, right? A step up from that, you have medically tailored food and groceries. Again, not prepared food. So people are still cooking and preparing these foods at home, but this is more food. It's meant to sort of provide some amount of meals to folks at the household level and provide a more sort of complete variety of the foods that Dr. Wetherill talked about being really important in the dietary pattern. And then at the very top of the pyramid, you've got medically tailored meals. This is probably for a very sort of health compromised population, people that have limitations in mobility and being able to actually get to the grocery store or being able to cook themselves. And they are, you know, fully prepared meals, heat and eat, and in general, very, very individualized to the people that they are serving. So designed by registered dietitian nutritionists for people who have lots of different complex health challenges. So you might need to have a diet that's appropriate for someone with type 2 diabetes, but they're also on a blood thinner, so they need low vitamin K. Like there's lots of things that they layer on top of each other. And then all across the continuum, clinician and program recipient nutrition education is critical. But we don't, in general, we sort of leave things that are only education-based out of this model a little bit because we're focusing on actually providing the food in the healthcare space. Because we know we need more dietitian services and more access to those services. That is a given in this space as well. But we also want to be able to support with the material support of food and or support for food. Okay, so we're going to talk a little bit, I'm going to transition to talking about the evidence base for food as medicine and why we're focusing on it in our upcoming report in January of 2022 with the Aspen Institute. But first, this is to say, because I know there are some healthcare payer representatives on the call, that there are live opportunities right now to integrate food as medicine interventions into payment and funding streams. And so that's something to really think about if you're going to plan sort of something and you want long-term sustainability of what you're planning. You know, there are ways to support produce prescriptions and medically tailored groceries and medically tailored meals in Medicare, in Medicaid, in dual eligible programs for people who are eligible for both Medicare and Medicaid. And then there are, of course, agricultural funding streams that can support temporary programs at this time. And so we have at the center summarized those opportunities and put them into what we hope is a digestible chart for you. You can find that here. So if you are curious about that, you can go and find these live opportunities to go ahead and start integrating services into healthcare. But when we come back at the end of the day, right, we know that it's really, it's a tall order to integrate anything new into the healthcare system, anything new. And so, let alone food, which is very complicated for folks. And so when we think about asking the healthcare system to come to the table on this, we want to know more about, you know, what works and for whom and for how long. So the Food as Medicine Research Action Plan was really an attempt to go deep into that question of what do we know and what more do we need to know in this space to really transform the way that we're thinking about healthcare in the next decade with respect to nutrition, and to really kind of start to get it right. We're not going to get it right from the get-go because the problems are too complex and we have too much other stuff going on. Nutrition is not in a vacuum, right? It's related to all these other things that are paid for in our society by lots of, or supported, or, you know, innovated about across lots of public and private programs and innovations and funding streams. So we want to really focus in on nutrition here and ask, what do we need to know to start to get this right in the next decade? So what we did with this report is we did a comprehensive analysis of the peer-reviewed research on food as medicine interventions. And then we did extensive stakeholder discussions on gaps in that research and where we want to see the research go in the future, guided by expert advisors like Dr. Wetherill, who is a very big gift to us. And then we issued recommendations for the next decade of research. What are we going to do? How should we do it? With what resources should it be done? Right, so that's what this report attempts to answer. So first of all, what the report will contain is an overview of all that peer-reviewed research on medically tailored meals and medically tailored groceries and produce prescriptions. If you are very anxious to see that broken down for you, it will be out in the report in January 2022, but because you guys are all engaging in conversations right now, we have put this chart together for you. It is available right now. It breaks down all of the studies, it looks at the details of them, talks about the intervention, tells you about the outcomes, tells you about the findings. And so that is available also for you as you move forward if you want some more details about what these studies actually say. So we're going to go through them in a really high level way. So what do we know? Well, we know a couple of really compelling, exciting things. And part of the reason that the policy space and the movement at the legislative and administrative levels took off in the way that it did was because of the initial research that we were seeing. And of course, everyone in the healthcare space gets really, really, really excited about anything that relates to costs or utilization of high-cost services like hospitalizations and emergency room visits and emergency transports, right? So like everybody in the healthcare space really sits up and pays attention to research that starts to sort of circle this area. And studies on some of the more intensive interventions in this space, like medically tailored meals, are consistently showing reductions in healthcare costs and utilization of those high cost services. And for folks that are coming out of the hospital, they're more likely, right, to go from the hospital to home instead of hospital to some kind of acute nursing facility as well. That is a huge thing for the healthcare system from a cost perspective. And then what we have to keep reminding ourselves, I think, in the healthcare spaces is also incredibly, it's huge for patients, right? Like to not have to go to the hospital, to be able to go home and be home, right? As opposed to in some kind of acute care facility, or to not have an emergency room visit, to not ride in an ambulance, is a big deal for patients as well. So that those studies are trending larger. The designs are more and more rigorous over time, and they are consistently showing these effects, which is why folks are really kind of paying attention to these studies now. But we also know that studies on these interventions, and then also on the less intensive interventions, right? So medically tailored grocery packages and produce prescriptions, they also show really critical benefits on lots of the areas that Dr. Wetherill really highlighted, right? So some of the condition-specific clinical outcomes like HbA1c in type 2 diabetics, reductions in stress, anxiety, and depression, like hugely important. Spending trade-offs, changes in dietary patterns, disease self-management, patient-provider relationships, right? There's some literature that shows that it affects that. And then of course, patient knowledge over time. So we have studies that are showing some really compelling and exciting data. And the research, which really kind of started to enter the scene only in 2013, if you're talking about these interventions by name, right? By the names that we're gonna give them. Medically tailored meals, produce prescriptions, and medically tailored food or food pharmacies or anything like that, food packages. We tried to be really expansive in our terms to search for this research. It really only starts to come out in 2013, which is pretty crazy, right? It's really new field that is exploding with information, and it's really exciting. So what will we know is another question that we kind of dive into. We have tons of cool stuff on the horizon that we won't have ready by the time of the report, but lots of randomized controlled trials, which are the sort of gold standard, especially in the healthcare space, although it can be really difficult to do them. And the good research in the food as medicine space by no means has to be a randomized controlled trial. And we're gonna really talk about the fact that like this field needs so much data that there is no lack of meaningful things to be done here to reveal more of sort of the mystery of food as medicine and its effects. But we have active randomized controlled trials, a lot focused in pregnancy, high-risk pregnancy outcomes, a lot on food pharmacies, produce prescription impacts, many in the cancer space, lots in type 2 diabetes, congestive heart failure, cardiovascular disease, and HIV. So all the stuff on the horizon. Then we have health systems and health plans across the country experimenting in this space. So we will have more of that data coming out, probably not in the peer-reviewed literature necessarily, but in the gray literature certainly, which is not published in a peer-reviewed journal, but health plans sort of coming out and saying, hey, we tried this thing and it was amazing, and our members didn't go to the hospital as often, and their HbA1c, their glycemic control is much better. So we've got a lot of program evaluations that we're anticipating. And then we've got some pretty big experiments in California, Massachusetts, and North Carolina, where we're really gonna see robust data on food as medicine interventions as part of broader sort of healthcare system transformation efforts. So we should see more in the next couple of years. And then the big part of the plan is what more do we need to know? And then how are we gonna figure it out, right? So we've got what research should be done with the goal of transforming our current and near current health system. And we've talked about this a couple of times, but like what works for whom, for how long, under what circumstances, what health conditions, what dose, right? How much food you have to give someone to change an outcome that you wanna see. What component of a multi-component intervention. So if you're doing something that is food plus nutrition education plus something else. What's working? Does it have to all be together to work? Can it be one thing and not the other to work? You know, what's really working here? And then what infrastructure is necessary to scale food as medicine interventions? Like, what does the healthcare system really have to have in place to be able to actually have a patient show up in your office, and you be able to identify them as needing something, and then you can make the referral and they get the thing that you want them to get, right? That's what we need. It's really actually quite complicated to do that, as you could probably tell me better than I can tell you. And so what do we need to do to our healthcare system to enable that workflow and that process to happen? I have lots of stuff that I see in the chat, and I'm having trouble reading it and talking at the same time. So anybody who wants to, Elizabeth or Dr. Wetherill, if you want to ask me as I'm going forward, I'm fine with that, but otherwise I'll just keep plowing through. I'm almost done. So here's some of the summary of some of the recommendations that we make in the plan. The first is to embed equity throughout the research continuum. And there's a lot of reasons for this. It's a good idea because it's the right thing to do. It's a good idea because it hasn't been done in the past necessarily, although it's being done more and more. And what happens when it's not, when equity is not sort of, when the participants in the research are not at the heart of what you're designing and doing, you miss things, and the research ends up not being as translatable as we would hope, right? We make mistakes in the healthcare system all the time with this kind of stuff, where we don't think and center the people who are going to be using the intervention or using the service. We are excited about programs that do certain things. And so then we're like, what, great, we did a program, for some people it worked, let's scale it up. And in the scale up, it ends up not working well, not being utilized appropriately, and there are barriers to being able to fix it in the long term. And so this is something just to pay a lot of attention to. And what that really looks like is really thinking about your participants in context, and the thing that you're designing for, you know, how are they contributing to that? Are they being part of the design? Are they giving you feedback about how it's going to work along the way? How are they being brought into the full process? How are they being brought into the dissemination of that research and results? And how is it of value to them? And there are ways, there are a couple of things we'll also mention about why we need to be careful in the research space in particular, and pilot research, to think about what's going to be valuable to the program participants. And then, of course, to all the clinics and the sort of other community partners who are doing this work too. We don't want to do something that doesn't have a lot of meaning and value at the end of the day, right? So really making sure that equity is embedded into that can solve some of those issues. Research should be designed to advance the field. That is a very a high level way to say what we need is to make sure that our research studies are large enough to observe the outcomes that we want to see. They have to be adequately powered. So this is something that Dr. Wetherill and others can explain better than a lawyer, but they have to be powered and large enough that to find statistically significant results for the outcomes that we want to see. So if you're going to have a study where you hope to change A1C, or you hope to think about someone at the end of the day having some other kind of outcome, you need to make sure you have a large enough sample size to be able to see that result from your intervention. And so there are calculations that you do for that. If studies are underpowered, what happens is we might see positive results, the results that we hope to see in a very small group, but that might not be as translatable to a larger group, right? So there are lots of things that you, there are a lot of reasons that you might see positive results and it might not be translatable in the research. So thinking about doing research that is adequately powered. And then also thinking carefully about what do you want the result to be? And is the thing that you're gonna do enough to, you know, influence that outcome? So if you're giving someone a very small amount of food infrequently, what do you really anticipate the results of that being? I think is a good question. And then thinking about qualitative research, very important and very, in this space in particular, underutilized, right? So we don't know a ton about what people like about the food as medicine interventions, what they don't like about it, what they find challenging about the interventions, and then the ways that they value the interventions beyond purely having enough food to be able to put food on the table for their families, right? I think Dr. Wetherill talked about qualitative research and some of the powerful quotes that that her study participants gave about, what is the value of this, or what are, they just want to feel like a human being, right? And that's a real driver of behavior. And we don't have enough of that kind of research in this space, so there's a ton to be done there. And then we want to explore the gaps in the literature. And we want to make sure that we explore things beyond utilization and cost, because utilization and cost, we're likely to see those kinds of changes in healthcare costs and in utilization of high cost services when the interventions are a little bit more intense, especially for short-term interventions, right? So we don't have any data on long-term produce prescription participation and what it does to you and what it does to your behavior change. We don't have that data. Most of the data we have is on sort of shorter term interventions. And so if we're looking for cost and utilization, you're going to want to deploy more intensive interventions in a population that has high health needs or very, very diet sensitive health conditions. So we're seeing a lot of that in like the pregnancy space, right? Because gestational age of the infant is linked so much to cost. And then we have like congestive heart failure and renal disease and diabetes, where you might see very significant changes after a very short intervention that's more intensive. But we want to be thinking about measures beyond utilization and cost consistently, because they're really, really, really important to the patient, and therefore really important to how the patient is going to show up in the rest of the healthcare system. And so I'm going to flip over to a slide in just a minute that has a list of those things that we've been sort of talking about among our group of advisors. What's really important here beyond healthcare utilization and cost that people can really start to think about, so that they can, so that we can make some real contributions to the literature on these metrics beyond this, and get the attention of the healthcare system focused on some of these, especially less intensive interventions and the benefits that they might have, both shorter term and longer term. And then we have public and private funders making robust investment in food as medicine. So we have in the report, we say, look, at the National Institutes of Health, you have a big job to do here. You should really be robustly funding in this space. In particular, we need longitudinal studies that have longer times where we look at these interventions for being deployed over a prolonged period of time, and looking at that in the primary prevention space, right? So like, could we intervene with someone who has prediabetes and prevent them from then sort of moving on to having type 2 diabetes? Is that an option? What else can we do here? I think, those kinds of studies, the NIH is really well positioned for that. And then there are really important roles for private funders, both individually to do a lot of the funding of this, especially qualitative research and feasibility and implementation science, right, that we need to have in this space, but also to think about partnering with these larger studies so that we could introduce an additional population into a study, for example, or think about making the study larger in order to make it powered so that we can report out results that then can be separated by racial category, for example, which we don't have a lot of that in this body of literature. And then we cannot ignore the context in which we all operate in the healthcare space. So there's lots going on here. SNAP, the SNAP amounts just were raised, right? And so we're going to see people have a little bit more to spend on food in this space. We've also seen the introduction of a couple of income support programs, like an increase in the child tax credit that was temporary, but but it was significant. And the results of surveys on how people were spending that money showed that the highest category of spending that they had for that was food, right? So people were most often using that child tax credit dollars or reporting that they were using it for food. So things that would increase purchasing power for food, we need to really be thinking about what the health impacts of those things are. And so thinking about how we can really get to the bottom of that in the health impacts of some of the public programs that we are operating, and then some of the changes to those programs. How do we understand the full range of health impacts? I think is an underexplored area as well. So we have some recommendations on that. So here's our little list, our cheat sheet of some of the interesting cost metrics of success for food as medicine interventions beyond impacts on costs and utilization. And so we see here on this list, right, depression is a huge one. Depression increased healthcare costs. So if we're influencing depression, we are likely influencing healthcare costs as well. So some of this, it's like a little bit, we can see this more easily. And we can then infer that things will change further down the line. Same with healthy days at home, right? That's another one where people having healthy days at home is linked to costs on the other side. Social connectedness and isolation. We've seen impact on substance use from a couple of these interventions. Medication use in particular. Sometimes people will be able to complete a course of cancer treatment if they're having a nutrition intervention, which is huge, being able to complete their treatment, or they're being taken off medications, right? Because they're able to sort of not need so many of the medications. And we've seen both of those things in this space. And then caregiver stress as well. There is lots of opportunity to explore household impact of food as medicine interventions, right? So in some cases, you might prescribe a medically tailored food package to someone who has type 2 diabetes, but they're living in a family and they are going to be sharing this food with all of their family members. But we're only collecting health data for that one person, where the entire family really is changing their dietary patterns, right? Especially if the person who you're giving the food to is the person who is providing most of the nutrition and preparing most of the meals. So there's data that we're missing here in the literature on that. So lots of opportunities here to be able to really make a dent in this literature and to add to it. All of these things I think are not unexplored because the research is really exploding, but it's underexplored, right? So we've got lots and lots and lots of really rich information. Even if we just start with these metrics and really sort of explore some of these things, we'll be contributing a ton to the field. So the key takeaway, I think, this is it. This is the last of my slides. It's just that there's no shortage of opportunities to meaningfully add to this evidence base. So I think, really feeling the power of that, everyone in this room should feel that. Qualitative research is critical to advancing the field and to making policy. It really moves policymakers. The qualitative research piece moves policymakers. So even if the cost and utilization data might not be there, we can grab and leverage the enthusiasm of policymakers with that qualitative research. Co-design of programs is really important. So making sure that the program is really centered around the participants' needs and interests and values and preferences. And then don't, of course, forget the provider experience as well. And the impact on sort of the provider environment, I think, is another underexplored area that we could do a lot with, and that would be really meaningful for translating some of these programs into policy. And then build on the findings of the peer-reviewed research. That basically means, like, don't duplicate what's already been done, right? There's infinite ways to add to the research. But what we don't want to do is studies that are sort of too small to get the to find the results that they're looking for. There are lots of ways to use small groups of people to get tons of data that would be really rich and meaningful to the field, but may not necessarily be about lowering A1C, for example. So thinking really critically about what is it that we want to do to add to the field here, I think is really important. But the opportunities are endless, and I'm really, really excited about the efforts of the Sunflower Foundation here and all of the conversation that we're having today to do just that and to really be kind of some of the foundation for good policymaking moving forward in the future. That's all from me, and it's been just such a pleasure to be here.
Well, thank you, Sarah. That was another great presentation. I hope everyone is getting the excitement that we were, Elizabeth and I, as we engaged these experts from across the country and started talking about the work that Sunflower hoped to do in this space. And, the fact that they were willing to come and share their expertise. And then the fact that Sarah said, hey, there's report coming out from the Aspen Institute, would you like to connect with that? And at that point, Elizabeth and I just ran out and bought a lottery ticket because it was just so perfect. So, thank you for that information. I think as we look at the chat, I mean, the takeaway from the chat is process, qualitative evaluation. Yes, I think the takeaway here is that the work that's happening on the ground, it can happen through initiatives like this. It does not go to waste. It goes to back build all of the evidence that's needed to further support good policy and good reimbursement. We're coming up here on a break. We need to take a quick 3-minute break so that our speakers can stretch a little bit, grab a drink. We expect that each of you are taking breaks as you need them, but wanted to leave time here for a couple of quick questions. If there are questions, I don't see any in the chat yet, but you can certainly unmute yourself if you have a question. Everybody's ready for that next break, and I think Sarah is going to be up next speaking. So why don't we go ahead and go to a short 3-minute break for folks to kind of stretch, and then we'll reconvene. We'll throw a timer up here so that everybody can kind of track that, and we'll be back in a few minutes.
Elizabeth, I just want you to know I'm going to go walk laps.
Good morning again and welcome back. I love the way the jazz music kind of faded away. Our next session is going to include all three of our experts this morning. You've just heard from Marianna and Sarah. We are happy to introduce, she won't be speaking right next, but she'll be part of our panel, Dr. Christina Bridges from the University of Kansas Medical Center. Now, she is more than just our token Kansan this morning. Dr. Bridges is conducting and leading some very important research around food insecurity and chronic conditions. She also has a very impressive background doing on-the-ground work with local food systems, so she brings that perspective. And finally, she is the 2021 recipient of the KUMC Vice Chancellor Award for Diversity, Equity, and Inclusion for her work in this effort. So we are pleased to have her as part of this panel. And then as a reminder, after this panel, some Q&A, we will roll right into the final presentation of the morning, which will be Dr. Bridges. So up next, our panel on the three models that we've just heard about to dive a little deeper.
Okay, so our team is actually gonna do some popcorn style for this presentation. So I think I have been nominated to advance the slides for everyone. We'll see how this goes. We all contributed to the presentation, but we have not rehearsed it as a team yet. So you can put in the chat how well you think we aren't doing in that regard. But I'm so happy to be here with Christina and Sarah to explore these models with you a little bit. So our objectives for this session are for you to at least be able to walk away and define and describe some key features of these food as medicine models that Sarah briefly introduced. We have a couple of different case studies for a few examples of how the models were actually implemented in real life, looking at dose and duration and components and what were the outcomes that those case studies observed. And then we want you to just start thinking by the end of the presentation about really who is each model suited for best. And in the context of your space, there might be a model that you have in your mind of what you wanted to do, but we really want you to critically evaluate the other two as well and think, okay, is this really the right match for the patient population that I'm trying to help? And so we'll start off with these intervention models, go into the evidence, and then kind of explore some best fit today. So as Sarah already defined for this presentation, we're going to do what was defined in the upcoming Aspen report, which is this spectrum of programs and services that are designed to respond to that critical link between nutrition and health. And they have two main components where we're looking at a provision of food that's very intentional to support health. And we see things like medically tailored meals, groceries or food assistance, such as vouchers for produce. And there has to be some kind of interface nexus with the healthcare system. So these three models are just depicted here. What you'll probably notice as we go through the case studies is sometimes there's a little bit of a gray line. For example, in the medically tailored groceries, I think that there's a gray line example that, you could probably make the argument that it's also kind of a medically tailored meal a little bit as well, but we'll get to that in a minute. So for just a reference definition, those medically tailored meals were at the top of that pyramid that Sarah introduced, and these are usually more labor intensive on the side of the system that's producing the meals, because you have classic chefs that are preparing very well-tasting meals, ready to eat. You're getting them usually delivered to a patient's home. They've been informed after an assessment by a registered dietitian of what that meal actually would be. And they're designed to really address an individual's medical diagnosis, symptoms, take into context their allergies, other medication, contraindications, side effects, things of that nature. Medically tailored groceries, in contrast, are really just providing people with unprepared foods that the patient is then expected to prepare on their own at their home. Usually it's a variety of items that would be necessary to produce a full meal. So we see representation in the common food groups, including produce, whole grains and beans, lean proteins typically. And all the foods are considered essential components of a healthy diet, trying to, again, move that dietary pattern towards a more health promoting one. And there might be some very specific foods that are introduced in these medically tailored groceries that are really important for the management of a particular chronic disease state. And then lastly, we have this fruit and vegetable voucher category where we're really just trying to address gaps in fruit and vegetable intake as really an important foundation for a healthy diet that's recommended for just about every type of chronic disease management. And they're given to patients where they can either redeem them at a farmer's market or at a other type of food retailer that's in the community. So what we're going to do now is move it on over to Sarah, and she's going to go over the first of the three models and kind of present us with some case studies from MANA, Project Open Hand, as well as FreshRx, and how they approached the design of these meals and what the outcomes were.
Yeah, thank you, Marianna. So medically tailored meals, so that they are near and dear to my heart because one of my first clients as a lawyer was the Food as Medicine Coalition, which is a coalition of nonprofits that produce these medically tailored meals. So MANA and Project Open Hand are members of that coalition. And like Marianna said, these are fully prepared meals and they're really designed for an individual sort of range of health needs. And what usually happens as well within the course of, folks getting meals from these organizations is that they also have access to nutrition counseling from the organization by dietitians who are on staff at the organization, so that if they have questions about, oh, hey, I have these medications and one says I should take with food and one says I should take later, like, can you help me sort of work out the schedule of the day according to the meals? And if they have questions about the meals or what they should be eating outside of those meals, they're able to do that. But in the medically tailored meals space, these three studies are really are great because MANA was the first study, the 2013 study that I mentioned, that first came out and really opened the door to healthcare integration for them. And so they were doing medically tailored meals for very, very health compromised populations. So we can't really stress that enough. These are individuals that had HIV sometimes and other diseases. So they had probably like 4 comorbidities, like sort of 4 things at once, were mostly homebound and received 3 meals per day, 7 days per week, home delivered to the patient's home. And then they heated them up and ate them at home. This is the first study that came out that really showed an impact on cost. And it was versus a comparison group. It was people who are enrolled in a managed care organization, a managed care plan in Pennsylvania, which is where MANA is based. And the folks who received the monthly healthcare costs, the monthly meals, their monthly healthcare costs went down a huge amount, 28% lower from baseline, 31% lower than the comparison group. Their hospitalizations, if they were hospitalized, first of all, they were hospitalized less, the hospitalizations were shorter, they were more likely to go home instead of to an acute care facility, right? So the medically tailored meals literatures continue to build on this, and we're looking at, I think, 2 very much larger studies published in the last 2 years that have shown a 16% overall total cost of care net reduction. And then also those emergency transports and emergency room visits down as well. So that's MANA. And then we have our Project Open Hand study. And so this went really beyond healthcare utilization and cost as the primary outcomes that they were looking at. So, thinking about what do we need to know about what's happening outside of just healthcare costs? So these were people living with HIV and or type 2 diabetes, which makes up a large portion of Project Open Hand. They're based in San Francisco, California. That makes up a huge portion of the people that they serve. So they had meals and snacks designed to meet 100% of daily caloric requirements. And so these findings looked at food security. So it increased food security, increased things that we want to see in that dietary pattern. Fruit and vegetable intake, fatty food intake decreasing, BMI decreasing, and then really good improvements in some of the depression scores, diabetes, distress, and self-management. Medication care is super important in the HIV space because when you adhere to medication, you can get your viral load down enough that HIV is no longer transmissible or is less likely to be transmitted, which is huge. And then also glycemic control, really positive impacts there. So that was Project Open Hand. And then we're going to talk about this study that's like not really like a medically tailored meal per se, but it's really exciting. So we wanted to talk about it here because it's one of the new sort of pipeline research areas that we're pretty excited about. So this is a nonprofit in Missouri called Operation Food Search. They are doing a FreshRx Nourishing Healthy Starts program. So this is for pregnant women on Medicaid who are experiencing food insecurity. And what they're getting is weekly meal kits that are scaled to the household. So they're getting these almost like a Blue Apron, right? Or a HelloFresh kit where it comes and it's portioned for you and there are recipes and you kind of put the food together. They're also getting videos and kitchen supplies and some of the wraparound social services, and the meals are delivered weekly. So this is kind of like an example of how we're making categories here, but sometimes things don't fit in the categories because this is a dynamic field. So don't feel bound by categories, I guess is the message. Like, do what makes sense for your patients and your clients and for you. But they did a pilot to test the feasibility of this. And one of the things that I think is very exciting about their design is they're really focused on bringing those participants into the study design. So they did lots of focus groups with the participants, especially around, the beginning, middle, and end of the pilot. They sought to really increase some of the skill sets of those participants along the way. They thought about how these participant stories were going to be used in disseminating some of the results, but they did see really exciting results, right? So food security increasing significantly, maternal depression symptoms going down significantly. Again, that is enormous, huge in the health outcome space, in the infant and maternal health space, and then also in the cost space, right? We want to always be thinking about how we message to different constituencies. And then they had good outcomes with birth as well, which is, again, very cost sensitive in the Medicaid space.
My question is, how are we going to do that? This? Yeah. We'll just put it in the wagon.
Yeah, I think if you could mute yourself.
Lisa, I think you need to mute yourself. Thank you.
I don't know.
I'll
send her a message in the chat box. Sorry about that.
We love Zoom.
Got it. Yeah, it just happens. It happens sometimes. Yeah, and so just to be able to see, the really dramatic impact of that first medically tailored meal study. I mean, this is why everybody got excited about this in the first place in terms of the policymakers and the Center for Medicare and Medicaid, right? Is that they saw this chart where these costs decreased so dramatically. And when we think about that, we really need to put it in context because we don't want to say that everyone's cost will decrease dramatically if you give them any kind of food as medicine intervention, right? That's not going to be practical. This is a very intensive intervention for a very, very health compromised and very sick population. But what we see here is that it is possible with nutrition to really have an impact on some of these outcomes. Next slide. Yeah, and so here's just another sort of really interesting chart of the specific outcomes, and you can see the cost differentials, and those have been consistent and large, right? So a 16% reduction in overall healthcare costs from an intervention net is enormous. It's like a unheard of thing in the healthcare space. So the problem that we have when we sort of go around and talk about some of the research in this space is people don't believe it. But these studies are getting larger, and as I said, the designs are getting more rigorous. So it is very exciting to be in the medically tailored meal space in particular. I think we'll see some real integration in the next couple of years. But to be thinking also, if it's not medically tailored meals, what kind, like if it's really like prepared meals that are right for your patients, or meals that come in something like a meal kit, you know, there is also research that is going to be captured in our report, and I can certainly send you that data as well, on meals that aren't so individualized, that are more sort of like a DASH aligned meal sent to the home as well.
Thank you, Sarah. Turn it over to Dr. Bridges.
Okay, thank you, Dr. Wetherill. So now we move our review of the evidence to what's known about benefits of medically tailored groceries. These models can involve distribution of foods. So it's not prepared foods, but it's enough food to make a full meal or several full meals. And it can be either delivered to the patient's home. It can be for pickup at a clinic, or it can be to be, you know, picked up at a community site like a food bank. And so those three models, we're going to talk a little bit here, and two of them are in process models, but we're just going to describe sort of the makeup and the plan of them. And so you can see that, and then talk a little bit more about a completed larger scale model. So next slide. So first, the program that I am leading or involved with at KU Medical Center. So we call this our Food RX plus Community Health Worker program. And so we have recruited adult primary care patients experiencing both food insecurity and type 2 diabetes. And we're recruiting from primary care patients from KU Medical Center primarily, and then also a smaller subset from Vibrant Health, one of the partners that's here today. And enrolling patients who have both food insecurity and type 2 diabetes with an A1C at baseline over 7.5. And so our intervention is 12 weekly home deliveries of fresh produce we're sourcing from the KC Food Hub, which is a aggregate of a bunch of farmers around the Kansas City area, and then also shelf stable items from Harvesters, another partner here today, which includes some milk, milk, oats, canned vegetables, low sodium and no sugar added vegetable or canned items, and beans and things like that. And the first box that we deliver also has a couple of cookbooks. It has A1C kits for measuring at baseline 3 months and 6 months after intervention, or 3 months after intervention, and blood pressure cuff. And so the unique thing about our program is that they not only get these food boxes, but they get a weekly visit from a community health worker. And these visits will include nutrition and cooking counseling. And it's really kind of tailored to the patients, because some of them know a lot about nutrition and cooking, and then some of them would like this information. So we really tailor it to the patient's needs. And also doing some healthy eating and some goal setting around cooking. Community health workers do an assessment of the knowledge and utilization also of healthy food access resources that these patients are aware of. So we have compiled everything that we know about, and everything that the community health workers from our community-based organization know are available and would be within a good distance of these patients, and let them know about them and ask them, are you using this? And if not, why not? So we're gathering a lot of information there, and hoping to see that at baseline and after the intervention, the knowledge will increase and the utilization of those resources will increase. And then as the community health workers work with the patients, they're assessing them on all of the social determinants of health, and then linking them to any resources that they may need. So if they have transportation issues, if they are having trouble affording prescriptions, medications, whatever, employment, just sort of anything that we can help them with, they're doing that. And finally, we have a control group that is only receiving the 12 weeks of food delivery, and then none of this community health worker intervention. And so what we're really hoping to see is that, those receiving the community health worker have more of a long-term sustained impact on their food security and hopefully on their A1C. So this project was ready to roll out March 2020. And then obviously we had to, postpone and change things a lot. So actually we're now hoping to enroll 85 patients. And originally it was 3 times that. And we had a shorter intervention originally, but with just the way that food insecurity changed and became worse, we wanted to give people longer immediate food relief. So our program really is immediate food, assistance and relief. So with these, bringing in these deliveries of food, but then hopefully working with the community health workers will affect that capacity building of individuals and really get them in touch with resources and maybe food resources that they hadn't, been utilizing. If they're not enrolled in SNAP, our community health workers can help them enroll, all those things, so that hopefully, on their own, once we stop the deliveries after 3 months, that they will continue to access food. And then I'll let Marianna talk about her project.
Yeah, so I'll just be brief, but we're also very similar to where Dr. Bridges is in implementation of a medically tailored food assistance program. And if you remember from the previous presentation, we talked about this clinic to community and community clinic type models. This is more of a traditional food pharmacy model where everything is delivered on site in the clinic, and there's not so much community connection, which is a limitation of our project, but it's also reflective of the resources and the bandwidth that we have at this time. However, what we are trying to do that's very different with this food first pharmacy is enact some systems change simultaneously with providers. So that providers actually feel a lot more confident and capable to not only talk to patients about food insecurity, but use food insecurity as something that will actually inform their care planning process, particularly for their patients with diabetes. And then also getting their self-efficacy up and their knowledge up on how to assess and advise patients to use food as medicine. Because what we know is that one of the single largest predictors of individual behavior change at a patient level is the provider telling them to change the behavior. It doesn't work all of the time, but it is one of the strongest things we can do. So we're equally spending time really with the providers who happen to be students at this clinic. This is a student-run longitudinal clinic for uninsured patients who have diabetes and hypertension. It's called Bedlam Longitudinal. And so we're training nursing students, social work students, medical and PA students to work together as a team to address food insecurity. And then we have dedicated project staff, though, outside of students that are helping to make connections with the patients at the clinic and based on patient preferences, as well as any physical disabilities that they might have that interfere with food preparation, we're customizing shelf-stable food boxes, as well as fresh produce. And then they'll also be receiving some cooking kit items that they get to select. And we also have adaptive cooking tools for people with arthritis and things like that, just to try to reduce those barriers in the kitchen for cooking whole foods. Our intervention is going to be 12 months. And the main things we're going to be evaluating is how well we're actually implementing the clinic flow system. And then we're going to really be tracking very diligently the program utilization and what food items are people actually selecting, so that we can have a better understanding of what those population needs are. So this is very much a quality improvement type project, I would say, rather than a research study per se. Okay.
All right, and then the final model, comprehensive diabetes self-management from food banks. So this was a larger scale project that was done in many different food banks across 3 states, actually, where patients were actually recruited from food banks. So they screened, I think, over 5,000 patients and found a little over 500 patients who had A1C over 7.5 and were willing to be part of the study. And so the food packages are all assembled at the food banks. The patients come to the food banks, pick them up. It's very similar to what we have in our food boxes, some fresh produce and also some dairy and legumes, nuts, fruits and vegetables, canned items. So these pickups are twice monthly, and they get 11 food packages. And this is a 6-month intervention. And what they found was that really the best outcomes from it were a reduction in food insecurity, and fruit and vegetable intake improved, and that the participants really liked it. So they preferred the diabetes food packages over what they normally would get at the food pantry. They enjoyed having the glycemic monitoring at the food bank. That worked for them. However, the main finding that, they were hoping to change here with the study A1C, there was no difference in A1C. And this is kind of one of those examples. This group did a smaller study before doing this larger scale one, and they did find improvements in A1C. And so maybe this just speaks to, the translatability that Sarah was talking about. Once you go large scale, now they're in 3 different states, they're working with, different populations. So maybe something was lost there as far as, what was beneficial to have an effect on A1C. Okay. And then because I'm very excited about community health workers, and that's a main part of our program at KU Med, I just really wanted to take a moment to pause and say, having community health workers in our intervention is just a great way to involve, these are people hired from the community similar to that we are, enrolling into this study. So, similar socioeconomic status, similar, medical conditions and health needs. So they have been essential to informing, the design of our study, and they have been there since really day one. And these photos were taken March 20, I think like the beginning of March 2020, where harvesters welcoming and brought us in, and we did this several day nutrition education for our CHWs so that we could have them do what was meant to be in-home visits with patients, and we had to change everything to have virtual visits. But I just wanted to highlight that, just bringing community health workers from a community based organization, first of all, not just hired, through KU, but they had already been working in the communities. So thank you. All right. So, maximizing the success of any of these projects, and any of these different models, it's just really important to look at, do we have input from the people that, we'll be hoping to involve in it as participants? Do our stakeholders and the partners that we have, are we able to get the amount of food that we want reliably? All of these questions. And, it's important to build that in at the beginning, because the best models, they'll be received better. People will actually, eat the food, pick up the food, eat the food if they feel like it's something that fits them the best. And so all of this, to honor patient autonomy and dignity is really important in all of this. All right. And then finally, we wanted to point out, the medically tailored groceries, it can be sort of thought of in 2 different ways. Is this what your intention is, to correct these gaps in accessing healthy foods for a certain population? And if that's your intention, is the intervention appropriate? Is it long enough? Is it going to sustain and be there always? Is this going to be a reliable outlet for people to access these groceries, versus is it more of a short term, we're giving people these foods so that they can experience them, maybe start to like them, understand how to prepare them more, and then try to figure out, where they're going to get them later. So thinking about it in sort of 2 different ways.
Okay, and I know everybody, it's close to lunchtime and we're getting probably glossy-eyed, and I know some of these tables are very, have a lot of stuff in them. So they're primarily there so that you can have them as a reference whenever you're thinking about how you might wanna design and implement the program you're going to explore, but I'm gonna wrap up just a couple of different case studies on the fruit and vegetable vouchers. So there was actually one project where they gave something called a Food RX card. And this study was conducted in North Pasadena, Texas, which is about 150,000 people in that population. So not particularly rural, but not also particularly highly urban. And the intervention happened in 2 school-based clinics as well as an FQHC. And the target population was families of pediatric patients who had screened positive for food insecurity. So they had, at the beginning of the project, they screened 549 families that were receiving care at these clinics and found that 331 had screened positive for food insecurity. So that's really who the intervention was designed for. Of those 331, they offered this voucher program, and 242 of the 331 did that initial acceptance, but then only 172 actually redeemed the vouchers. So if you're staying with us in the lunchtime, after the lunchtime break, we'll kind of talk a little bit more about reach of a program, and are you actually going to get response like you want for the people who you've identified at high risk. So this is a pretty good example of, for this particular clinic, only about 50% of the people who they had identified at high risk were even really being technically reached by the intervention. But the medical provider was the one responsible for issuing the card. It was redeemable every 2 weeks for up to 12 times at a partner food pantry that was collaborating with the program. The dose was pretty high. If you look at that, 30 pounds of fruits and vegetables that the families could select their choice of at the food pantry. So it wasn't a traditional model where they had no say. They were able to pick the variety that they want. And then they also had some supplemental healthy foods, but it was not very much, which is why we decided to call this a fruit and vegetable voucher intervention still. And then also part of this project is they did some staff trainings and ongoing technical assistance for the healthcare side as well as the food pantry side to make sure the program was being implemented as planned. And it was a 6-month study. So from baseline, what was really interesting to note is that we know everybody was food insecure at the start because that was a condition for eligibility of the intervention. So by the 3rd visit at that food pantry, the rate of food insecurity went from 100% to 10%, which is remarkable. And I think really speaks to the dose, the amount of the food assistance that was being provided. And then for those that continued and redeemed all their visits, the rate of food insecurity was only 5.9% by the end of the program. And 99% of individuals reported eating all or most of the food that was being provided. So you may see this and say, gosh, 30 pounds, that's a lot of food, must be a lot of money. Since this was in partnership with a food bank provider and food pantry provider, the actual cost per person was only around $12 per visit. So not very much from the budget side of the intervention. The value was obviously a lot more, but the cost, because of that food bank partnership, was a lot less. In contrast, there is another study, which on the surface kind of looks a little similar because it involved giving people credit to get fresh produce, but this was called the Fresh Prescription Program. It was done in Detroit with just one federally qualified health center, and they targeted, similar to Christina's example, people with type 2 diabetes that had poorly controlled A1C. They chose their threshold at 8% or above. They identified 530 people that were eligible. This was a randomized trial design, so only half of the people in that pool were randomized to receive an invitation. And of the 265, only 63 accepted. So again, Another example of reach. The project was implemented by community health workers who issued people a Fresh RX debit card and they also gave a brief orientation to the program. And this FQHC actually had partnered to have a farmer's market operate in their parking lot. So that was available publicly to anybody. So basically it was just a card that could be redeemed at this publicly accessible farmer's market that was operating 15 weeks during the primary growing season. And they got a $10 credit redeemable up to 2 times across those 15 weeks. They found that A1C dropped by about 0.5 percentage point within the intervention group and no change within the control group. They did not see an impact on BMI or blood pressure. And frankly, I was a little surprised to see that the A1C dropped this much. But it could be that other ripple changes in eating behavior happened, but really $10 of produce at a farmer's market is a lot different from 30 pounds of produce that they were getting in the other study through the food pantry design, even though the cost for the program implementers was probably about the same per redemption. So just some nuances to think about as you do your planning process. And then lastly, the Vouchers for Veggie program is a very large program implemented in San Francisco. Lead evaluator of this is Hillary Seligman, an expert on food insecurity and health. And its population is just a generic lower income population, served over 21,000 families per day to date. And this project gives $20 to $40 worth of fruit and vegetable vouchers redeemable at a variety of retailers. People can access the vouchers for 6 months or more. And that level of intervention, generally speaking, translates to about 1 extra serving of fruit and vegetable combined a day, some improvement in food security scores by almost a point, and 94% of people who participate in the program say that their health on a self-reported level subjectively has improved. I'm not going to describe every single bit of these figures for you, but I think they're a really nice example of the importance of process evaluation. So this is from the first Texas study that I talked about with the 30 pounds of produce, and they went to the food pantry to redeem their voucher for that. You can actually look and see what the participation rates were by visit. So 71% of people given that initial voucher made it once to the pantry, and only about 18% took advantage of all 12 visits. So you can not only get some ideas about how much your project might cost long-term, you can get some estimates of what your redemption might actually look like, but this could also give you an opportunity to do some qualitative interviewing with people who came every single time and why did they come every single time versus people who maybe only came once or twice and stopped, just to see if your program's actually doing the full reach that you would like it to. And then again, showing how the dose was pretty good for people in terms of being able to lower food insecurity. And then although there were some staples that were provided in addition to the fruits and vegetables, protein, grains, and dairy, what you see is that the fruits and vegetables were actually across all visits were what people said they needed and wanted the most for their health. So prioritizing those fruits and vegetables and some confirmation for that. This is the middle program that I presented, Fresh RX. Similarly, you can see utilization rates varied by number of visits. So again, just something to think about in terms of process evaluation design. And I'm going to conclude my part of this presentation and then pop it back over for the others to comment on. But this was a really interesting article that was just published recently that looked at the San Francisco voucher program. And what they found was that these vouchers really make the biggest impact on people who are eating a little bit of fruits and vegetables at baseline, but more so than for people who aren't eating any vegetables at baseline. So that really gets at readiness of a population. And we oftentimes think of people as these homogenous groups, but really there's a lot of variation that we want to take into consideration. So what they found was that these vouchers were more helpful for people where their baseline intake was neither very low or very high. And also they found that smaller household sizes responded better or had bigger outcomes related to the vouchers. And that makes sense because the vouchers aren't dosed by household size. They are just a flat amount that are provided. And they also found that smaller vouchers more frequently may be more impactful than a single monthly voucher, the same equivalent financial amount. Okay. I think, Christina,
yes. This is me, but I think we will kind of go quickly through this because a lot of selecting a model talk is what we'll be, I think, focusing on with the clinics in the afternoon. But it's just really important to understand, the reach, who could this help? Do I have input from them? The effectiveness. Also, is the impact, can we provide something that will actually impact, an outcome that we are hoping to impact? And then, what partners do we need to have? What does the current system look like? And the sustainability, is this something that, clinic staff is willing to adopt and implement, and then ultimately institutionalize the program as a standard of care? And that's really important. So the next slide kind of just goes into all of those areas more in detail. You all will have these slides. I think the best thing to point out is just, the reach and effectiveness are kind of more about the participants, and then the adoption and implementation is more about you as the person designing and then implementing, the intervention, and then also your, all of the partners and staff and everyone that makes that up. And then together, are you able to, deliver something that you can measure the maintenance and sustainability of it, and figuring out when we measure that and how we measure that is really important component. All right, and then Sarah already went over this, but now you know more about each of the models, and so you can kind of see where they fit in. Okay, and finally, I think we should just end with this advantages, disadvantages. And kind of the interesting thing here is the way that there's like a gradient of burden, first with those delivering the implementation. So, the clinics and the food suppliers and all of you who are designing, it's hardest with medically tailored meals. There's so much input, and then it's a little bit less if you're just giving them groceries to fix themselves. And then it's, the least amount of effort on your part is giving them a voucher to go and, redeem. Then you look at the gradient in reverse for the participant. And so, the least amount of burden on the participant is the medically tailored meal. It's all prepared. It's, they've told me exactly what I should eat, and all I have to do is eat it. And then in the middle, we have the groceries where they have chosen the groceries for me, and they've either delivered it or made it very easy for me to get these groceries, but I now have to cook them, and maybe I've been advised on this, but I have, the burden kind of, and the costs and the labor and all that goes on the patient. And then finally, the fruit and vegetable voucher is the most burden on the participant, because they have to remember to get there and remember to redeem it, of all the ththings they have going on. And then they have to choose what to get and how do I prepare it? And I don't know, and so all of that is the burden on the participant. So that's interesting to point out, sort of the inverse relationship there. And then I think this can go with the participants to sort of read over the additional considerations, unless you wanted to point something out. Marianna.
Well, I think for those of us who are going to do the afternoon conversations, we'll dive into a lot of these, and they're pretty self-explanatory. And I think we've kind of covered most of these elsewhere in the presentation. So I just want to follow time. Sorry. Okay, and I think that those were all the slides. So yeah.
All right. Well, another great discussion. I think as we are now thinking about, this whole issue, as important as it is, as we move into thinking about how we, or what we might do, as we think about casting a net out there, if we've cast a wide net in terms of like, we need to do something, we want to do something, this presentation really helped kind of hone in on where you might want to strike that balance between kind of this wide casting of net versus some more targeted interventions through a food as medicine approach. As we wind down our morning session, we're going to turn now to Dr. Bridges to talk a little bit more about the equity considerations in a food as medicine approach. So we'll turn it now to Dr. Bridges.
Okay, thank you, Brandon. So I was asked to talk a bit about equity in terms of food as medicine, or really any health intervention that we would take on. And that's because, I mean, Sarah said this earlier in her talk, and I know that Marianna and Sarah have mentioned equity and talked about the components and how important it is. And so I really liked what, Sarah said, to embed equity really first because it's the right thing to do. That was kind of what I was going to say too. And because it's essential to getting those health outcomes that we all want for all of our patients, for the entire population. But then the more pragmatic reason is because it's going to make your intervention work better. It's going to be more successful. We have decades and generations of health disparities that we've seen. And that has been, as she mentioned, because equity has not been really at the forefront. And so I could have chosen to show you any kind of disparity. I know you all have heard this before. I mean, it's horrible, but it's just become something that we see over and over, that by race, ethnicity, disparities exist pretty much in any health outcome, and even life expectancy. And so we've seen this over and over, and not to become desensitized to it, it should be so shocking to us. But this is specifically disparities in food insecurity. And this is a measurement of very low food insecurity. So if you remember Dr. Wetherill's continuum, this is like that red box where it's very critical. That's the very low food insecurity. And this comes from that Produce Prescriptions US policy scan that Sarah was talking about before, that she was part of. And in 2019, for Black households, they had the highest very low food insecurity, 7.6%, Latinx households 4.9%, and then white households 3.3%. But then look at the change, due to COVID, really, when you looked at the numbers in 2020, they all went up, but these, disproportional increases in the households of color. And so, that's the part where, look, we've all seen that before. We know there are disparities, and then there's the question, well, what do we do? And how do we, what can I do? I'm only part of the system. And we all have those, I think, reactions and questions. But what's important to remember is that we are part of the system, the individuals, wherever we are, at a research institution, at a healthcare organization, at a community organization, wherever you play your small role, you're part of a larger system. And so we as individuals, I think, need to really take a look at and understand why these health disparities exist. And that will help us determine what we can do about it. And so I know that many of you this might be, a refresher for many of you. Some of you maybe haven't looked at it this way before. But this is a slide that I like to use to illustrate this continuum of factors going, from upstream to downstream. And so on the right side, this is what in healthcare we're normally dealing with, right? The mortality, disease, and injury. This, I know I don't have a lot of time, but Marianna really inspired me with, kind of in her talk, where she kind of talked about her personal journey and how she came into the work. And this illustration has come to me I visualized sort of my career in reverse. And so I started here on the right side. I mean, my degree is in microbiology. I'm studying very specific disease aspects. But then I started to be more interested in the inputs, and especially understanding gut microbiota and how that impacts health and the systems in the body, but what you put into your body helps that. So I kind of moved upstream and learning about, risk behaviors. So what people are able to eat and choose to eat and how that affects everything, and studied nutrition. After I graduated, I went out and worked in community organizations and did a lot of nutrition education, food access work. And really that was like the bridge between behavior and then the living conditions, the access point. And then after that, moved to where I am now in a clinical department at KU Med in family medicine, but with a heavy, public health and health equity framework. And so started to really learn about what goes into what we call, the social determinants of health. That's sort of these living conditions here. And then further in the last 5 years or so, just really waking up to seeing what's even upstream of that and these social inequities, right? And race and ethnicity being the most blatant and the most dramatic, that has an impact because of the history of oppression and racism in our society. But there are other, there's, other forms of oppression and inequity that people are experiencing. And so we use that when we talk about race and ethnicity a lot at the forefront, but really understanding all of the ways that people are impacted by things way outside of their control. And so this is another way to look at that. And I like this because it really calls out all of the social determinants of health in blue. And so these are sort of the, indirect ways that these upstream factors, forms of oppression, racism, but also classism, ableism, all these different bubbles. And I left one blank because it's like, what else do we know? Or like, what is in your community specific to that? Because you may not have a community that has a very large component of, racial ethnic minorities or marginalized communities, but a different population could be the marginalized community. So they all impact these different items in blue. And these are sort of the indirect ways that they impact health. And then there are very direct ways that these impact health through stress, which has been mentioned before. And then, that bias that's in that clinical interaction. But I also want to call out health behaviors here, because I think sometimes we see, the factors that impact health represented sort of as that like circle where you see your, the clinic interaction, and maybe genetics play a little bit. And then you have the living conditions play a larger portion. And then you have health behaviors playing a larger portion. But to me, health behaviors are so informed by the social determinants of health and the living conditions and your environment. That's what that great, quote that everyone wrote down from the earlier talk is that your choices, reflect, or your behaviors reflect what you even have, what your choices could be. And so they just all are interconnected there. And then if you further, break down, so we talk about those terms of, forms of oppression like racism or sexism or ableism, but what do they really mean? Like, what are the symptoms for an individual or people or a community? And those can be the learned bias that we all have wherever you are in your identity. It's the impact of intergenerational poverty, why people of color are more likely to be in a lower socioeconomic status. People want to say, no, it's not really about race, it's about class and poverty, but what's upstream of that? What funnels many people into this intergenerational poverty and experiencing adverse childhood events. The internalized impact of oppression. So the way that you may not feel comfortable going to a certain part of town because you have internalized your, people marginalizing you and, feeling like, I don't want to go to the farmer's market in the white part of town. I don't feel comfortable there. I'm going to be looked at, all these different things. The fact that we have very segregated communities, and so we don't even talk or know each other very well. This concentrated poverty in certain communities and not others, so I could go down the list, but just finally looking at the stress coping behaviors that really inform those health behaviors. And we've kind of mentioned that before. And so as we're thinking about things like being intentional about equity, and whether or not, we all need to do some more personal growth, whether or not you all, have been, going to classes about this or reading books about this, wherever you are on the spectrum, we all have implicit bias and we can all unlearn it. And so it's not about, what are my, or do I have, blind spots and biases? We all do. Just look for which ones you have. And so whether or not you bear any personal responsibility for crafting any of these societal institutional isms, it's all of our responsibility to eradicate it. And they can be addressed through continual and intentional work, individual work within your organization and within your community. And so it takes intentional effort. And that's why we wanted to take a few minutes to talk about it explicitly, because it's not going to just get better on its own. We haven't been doing it. We haven't been focusing on equity. And so we need to change and do that intentional effort. I'm looking at my time. And as I mentioned, it's not all about race. It's not all about any specific form of oppression. It's about all of them. And I love this visualization. And this gets into intersectionality. So wherever you are, we all have identities that bring us either closer to power or further into the marginalized zone. And so this, you can look over this when you get the slides, but wherever you are, you're going to have a little bit of power and a little bit less power. And so it's important to understand your patient population and what they're experiencing and, where they may lie in this wheel. And then here's that visual that I know you've all seen before about, equality versus equity, but this is my favorite one because although the people in the picture are oddly colored, there's no difference in the people. Some of them, they show like a tall person and a short person, but that sort of reinforces that idea that there's like a biological difference or some sort of inherent personal difference that is, where some people need more help because of something about their person. But this one I really like because it shows it's really the ground we're standing on is different. And that's because of, the intergenerational effects of whatever form of oppression has happened to your family or whatever, so that you now are growing up with, this environment compared to the person next to you. And that's the ground. And then the fence is showing that, barriers are literally higher for other people because of current day oppression and the way that they're treated, and then the way that they see themselves, and just the way that everything is sort of set up. Okay. And so our hope, for all of us going through this is to have an equity mindset when we're designing an intervention. So you need to ask, and this has been said, by the previous presenters too, what assumptions am I making? Am I assuming that all of my patients are able-bodied and could stand and prepare their own meals? Am I assuming that they all would like these types of food? Am I assuming that they have the transportation to go pick this up at a food pantry or at the clinic? Have I really listened to lived experience? Do I have existing patient advisory groups? Could be, come up with a way. Have I employed community health workers who live in these communities and can really inform this? So who's at the table and who's missing? And then what are the structural forces in my community that could be impacting patients? And then finally, no, maybe this is not final. I just want to talk about stigma because the internal language that we use when we talk about things, this issue like food insecurity, that may not be appropriate when we're patient facing. So I've found in different communities across the state that I've talked with that some people don't like to use the term food insecurity and would rather talk more about, healthy food, bringing in health and do that health focus. This is about improving your health conditions and less about, not being able to afford food. And because we don't want to turn anyone off, we don't want to invoke shaming and the stigma as far as people saying, I don't want a handout and I don't want to be perceived as needing help in that way. But it's different when you just think about, people anywhere on the socioeconomic status probably need help improving their diet. And so we can all come together around that without it feeling like certain people are being, targeted for this kind of intervention. And that comes to the next part, the screening questions, which I think Sarah already mentioned, or maybe it was Marianna, about, normalizing the screening part of it, because a lot of people feel like, why are you asking me? Was there something about me that made you ask me if I was food insecure? And so really highlighting that all patients are asked this, or maybe asking it in a different way or using different terms, and even knowing what terms resonate best with your patient population. And finally, we know that only 45% of those eligible for SNAP, or 45% who are eligible aren't signed up. And a portion of that could be stigma and feeling like I don't want to make it seem like I need a handout and all those. And then similarly, a similar proportion of patients who indicate a need on a social determinants of health screening then indicate that they don't want help. So at KU Medical Center, we've been doing this now since 2017, screening all primary care patients on an 11-item social determinants of health questionnaire. And then we have a final question, would you like help? And it's about 45% of people who indicate that they have one or more social determinant of health need, but don't want help. And we think that stigma could be involved in that. So here are just some individual, things, because we can't change, the big system, but you can change yourself as a person in the big system. And so I can sort of let you read through these on your own, but it's about being aware of your bias, being honest with yourself and not being defensive that you don't have bias, and avoid blaming yourself. There's too much work to be done to get lost in the shame and guilt and, blaming or trying to be defensive. Realize when you need to slow down, because we all do this sort of automatic thinking, and, get input from others, engage your patients, remember why you're doing this in the first place, and empower your patients and partners. My final slide is just that, there's nothing we can do about the fact that there is a backdrop of distrust and concerns about discrimination, disempowerment. But what we can do is elicit a patient's perspective of illness, and then also of any interventions that we might come up with, and that this is going to enhance trust and respect, empathy, understanding. We're going to have shared decision-making, and then ultimately, patient engagement and autonomy that will lead to a successful intervention and improved health outcomes, because that's, the whole point.
Thank you so much, Christina. That's a lot to absorb. And as you were going through the last slides, I was reflecting about who is not part of this conversation today, but needs to be and will be in the future. And that would be the recipients and partners and the end users of any food as medicine programs. So, and that's something Dr. Wetherill mentioned to me the first time we spoke, and we are very aware of that and look forward to having a convening where they will be part of that conversation as well. Well, thank you very much. I'm going to make my remarks very brief here. Thank you to our amazing speakers, and especially Sarah, who I know was able to pop in and give us a whole morning, which we appreciate. And I understand now you're headed to a meeting at the Congressional Budget Office to talk about this very topic. So talk about street credibility, folks. If you're feeling a little shell-shocked by the information like Brandon and me, that was kind of the point. Our goal today was to give you a very high level, big picture view, some targeted drilling down just to whet your appetite, knowing that this is not the only conversation we'll have. This is going to be the first of many on this. So speaking of appetite, here's what happens next. To our external stakeholders that joined us this morning, we will send you all the materials that we have promised over the next week. Reach out to Brandon or me if you would like to have any one-on-one conversations. As follow-up, we would love to talk. We're going to throw up the shot clock in a minute for a 3-minute break. During this time, external stakeholders can log off and enjoy the rest of their Friday. Clinics and food assistance partners, we need you to come back in 3 minutes, but we'll only keep you for a few to give you your lunchtime assignment. Whoopee, right? No. And we have a few changes to the agenda this afternoon, which we think will make it go even more smoothly. So the shot clock's going to go up. We bid farewell to our external stakeholders and thank you for your time this morning. And clinics, we'll see you back here in 3 minutes. Thank you very much.